The public comment portion of the 1115 waiver review, we'd ask that you please sign in. There's a sign-in sheet over there. That's how we will move forward with the public comment portion. No, I don't do that.
No.
I'm muted. I'm not even on. Okay. Test. Sounds better now. Great. Okay. I think we are ready to begin then. So we can call the meeting to order. It's 10:05 a.m. Thank you all for being here. Good morning. Very full agenda today. Just a couple housekeeping items and before we move to introductions of committee members. As I mentioned, this is a unique special meeting. This is the annual report and opportunity for public comment around our 1115 waivers. That's a CMS requirement that we conduct this special meeting on an annual basis. So you'll see that we are joined by a court reporter who will be transcribing the public comment portion of this particular portion when we get to the HIP section of the agenda. So again, if you're here for public comment, please sign in so that we can call you up to the podium, and we will take that public comment immediately following the presentation on the 1115 waivers. With that, I think we can go ahead and introduce committee members, and we'll start in the room. Representative Karakoff, do you want me to start with you?
Mike Karakoff, State Representative, District 30.
Good morning, Ed Clear, State Representative, House District 72.
Shelley Yoder, live in Bloomington, and I serve Senate District 40. Good morning.
Sydney Moulton with the Indiana Council of Community Mental Health Centers.
Blair Hadley with the Insurance Institute of Indiana.
Luke McNamee with the Indiana State Medical Association.
Amanda DeRoss, not a member, but a presenter.
Lynn Mong, also not a member, but a presenter. I'm the director of Hip and Hoosier Healthwise.
Andrew Securis, I'm not a presenter, but I am a presenter, not a member.
State Representative Chris Campbell, West Lafayette, District 26.
Cora Steinmetz, Medicaid Director.
Holly Cunningham Piggott, I am a presenter and I am the Director of Care Programs.
Victoria Garcia Wilburn, State Representative, House District 32.
Thank you. And then we could just begin online. And I can try to assist in calling on people. Senator Lyson. Senator Lyson, maybe. Oh, there. Senator Lysing, I think, is getting off of mute, but Senator Jean Lysing is present. Julia Kettner.
Hi, Julia Kettner with the Indiana Primary Healthcare Association.
Senator Charbonneau.
Yep. Senator Charbonneau represents the 5th Senate District.
Brandy Foreman.
Brandy Foreman for NARF.
Dick Road.
Dick Road with the Indiana Psychological Association.
Katie Feely.
Hi, Katie Feely, CEO of the Indiana State Nurses Association.
Danielle Coulter.
Danielle Coulter, Indiana Speech Language Hearing Association.
Ed Rosenbaum.
Ed Rosenbaum, sitting in for Shane Springer, representing the Indiana Dental Association.
Herb Hunter. Reflect that Herb Hunter is present. Magdalene Cremens. We can reflect that as well. Evan Reinhardt.
Evan Reinhardt with the Indiana Association for Home and Hospice Care.
Kim Williams.
Kim Williams, Indiana Academy of Ophthalmology.
And Richard Nussel.
Richard Nussel, Indiana Osteopathic Association.
Thank you. And Senator Fedor.
Good morning, Fadi Kadura, Senate District 30. Good to see you.
Hi, Representatives Robin Shackelford, House District 98.
Great. Okay, thank you so much. So at this point, I will entertain a motion for approval of the May 2024 minutes. Any corrections that anyone saw from the minutes? We do have copies of the May meeting minutes here in the room.
So moved.
Oh, thank you. Senator Charbonneau moves. Do I have a second?
Second.
All in favor?
Aye.
Then we'll reflect the approval of the May 2024 minutes. At this point, we will have a rulemaking update from Amanda, one of the FSSA staff attorneys.
Hello, good morning. I just have one quick rule to present today. And as always, if you have questions about the promulgation process, I'm happy to answer those. So this is LSA 24-182, which we call the HIP prescription drug supply rule. This proposed rule amends 405 IAC 10-7-6 to allow HIP basic members to access 90-day prescriptions, which is increased from 30 days. So the rule has already gone through the public comment period, and it was submitted to the Office of the Attorney General on August 2nd for their review and approval. And once they review and approve, it will be submitted to the governor's office for their review. And if nobody has any questions, that's all I have today. Thank you.
Any questions? All right, very good. Oh, Senator Lysing's hand is up. She had indicated in the chat that her audio might not be working. So if you're online and your audio is not working, feel free to comment in the chat and we'll try to monitor that and read out any questions. Sarah Boslett with Indiana AAP is also now in attendance and is joined online. All right, I think we're ready to move to the substantive updates. And this is the special meeting for the HIP 1115 waiver and the substance use disorder and serious mental illness SMI 1115 waiver. And so we will start with Lynn Mong for this presentation.
Thanks, Cora. As Cora mentioned, my name is Lynn Mong. Good morning, and I am the Healthy Indiana Plan and Hoosier Healthwise Director for the Office of Medicaid Policy and Planning. And today I'm going to be presenting the Healthy Indiana Plan annual update in accordance with federal post-award form requirements. And topics we'll address include the HIP delivery system, eligibility and populations, updates to the HIP program, federal reporting, enrollment, and HIP service utilization. Next slide, please. HIP is delivered through a managed care delivery system, which means members are enrolled to receive services through one of 4 managed care entities under contract to the state. And those entities are Anthem, CareSource, Managed Health Services, or MHS, and MDWise. Managed care entities are also sometimes referred to as managed care organizations or health plans, but for the sake of brevity and habit, I will refer to them as MCEs today. HIP members are given an opportunity to select an MCE at the time of application, and they have an opportunity to change their MCE each year during the annual plan selection period from November 1st to December 15th, or at any time for just cause. There is an additional process for members who were unable to participate in the MCE selection period, for instance, if they were in a different Indiana health coverage program, and those members may call the enrollment broker and select a new MCE within 30 days of starting in HIP. The state contracts with an enrollment broker, Maximus, to provide unbiased answers to members' questions and assistance with making an informed decision about which MCE to select. One of the many benefits of a managed care delivery system is that the MCEs offer services in addition to those they are contracted to deliver, called enhanced services. The state encourages the contractor to cover programs that enhance the general health and well-being of its HIP members, including programs that address preventive health, risk factors, or personal responsibility. These enhanced services are above and beyond those covered in the HIP program. For example, only those HIP members who receive estate plan benefits are required to receive non-emergency medical transportation. But some of the MCEs provide that transportation coverage to HIP members and plus or basic level of coverage as an enhanced benefit. Twice a year, a health plan summary is updated and posted to the Indiana Medicaid webpage, detailing the differences among the MCEs in order to assist members with health plan selection. Next slide. HIP provides health coverage for adult Indiana residents between the ages of 19 and 64. Household incomes must be under 138% of the federal poverty level, and members cannot be eligible for Medicare or any other category of coverage. The eligibility populations found within HIP include the newly eligible population, also sometimes referred to as the expansion population or the new adult group. And this group is referred to as newly eligible because they wouldn't have qualified for full benefits, benchmark or benchmark equivalent benefits under the state's rules as of December 1st, 2009, prior to the Affordable Care Act. Indiana receives a higher FMAP or federal financial participation for this population. Low-income parent caretakers are parents or caretaker relatives of dependent children under age 18 whose household income meets the low-income standard. The maternity population includes individuals who are pregnant or in their 12-month postpartum period. The medically frail population consists of those who have a chronic health condition, a disability that impairs ability to perform one or more activities of daily living, or a combination of such as determined by applying underwriting guidelines to claims and pharmacy data or member self-report. And the transitional medical assistance or TMA group consists of former low-income parent caretakers who have had an increase in income that would normally make them and sometimes their children ineligible for coverage, but whom are allowed to continue to receive coverage for a minimum of 6 but up to 12 months in order to ease their family's transition to a new employment status or earning level by protecting their HIP from closing during that time. And as you can see from the Venn diagram, those who are in
Sorry, if you are online, if you would please mute. Thank you.
As you can see from the Venn diagram, those who are in the medically frail, maternity, low-income parent caretaker, and TMA groups fall into the state plan bubble. And that's because those populations would have been eligible for full benefits prior to the Affordable Care Act. So they must continue to receive that same level of coverage, even if they are falling into HIP categories due to their income level. And next slide. A couple of updates since we talked last year. We also talked about rate equalization last year, but the efforts continued into this year. OMPP worked with legislators to modify current state requirements to align with federal requirements and to pass a biennium budget inclusive of appropriation necessary to implement programmatic changes. The rate equalization project aligned provider reimbursement across all programs as of January 1st, 2024. Physician, lab, school corp, and durable medical equipment rates are reimbursed at 100% of the previous year's Medicare rates, and dental and non-emergency transportation rates were developed. Also, in the last 12 months, there were a lot of continuing PHE unwind efforts. So Nanis Spinner, the Director of Eligibility and Member Services, has been giving regular updates to the MAC and holding regular stakeholder meetings to share what we've been up to. But to recap briefly, we collaborated with MCEs through April this year to provide a monthly list of members for redetermination so that targeted outreach could be conducted to remind and prompt members to complete their redeterminations so that they could maintain their coverage if still eligible. And those same efforts were duplicated for those who were set to close for procedural reasons so that the MCEs could target outreach during the 90-day reconsideration period to assist individuals with regaining their coverage without the need to reapply. We also worked with MCEs to ensure their systems were prepared for the resumption of policies that were paused during the PHE, and we developed materials for stakeholder use in assisting members with maintaining their coverage after the resumption of policies paused during the PHE. Many non-PHE related changes were implemented during the time the policies were paused for the PHE. So when resuming a policy, it was necessary to evaluate how to do so through a lens different from the one in place when it was initially paused, which required a multidisciplinary, multi-agency effort and all of our combined critical thinking skills. Next slide.
Lynn, sorry to interrupt. One good question from Representative Campbell. PHE stands for Public Health Emergency, so related to the end of the continuous eligibility period.
Yes, my apologies. Okay. And as a refresher, here's a high-level overview of our federal reporting requirements for HIP. We must submit 3 interim evaluation reports and 1 summative evaluation report to CMS. A design was submitted to and approved by CMS outlining how Indiana Medicaid will work with an independent evaluator to collect and analyze program data related to the approved hypotheses. Drafts of the independent evaluation reports are submitted to CMS as they come due and posted on Indiana's Medicaid website for public access. Currently, the HIP and federal reporting teams are working with our independent evaluator on the interim evaluation. That's the one that's highlighted. For the demonstration years 2021 through 2023, which we will submit to CMS by the end of this year. And we look forward to sharing the findings from that report during next year's HIP annual update. The other component of our HIP federal reporting requirements are quarterly and annual monitoring reports. The federal reporting team develops a monitoring protocol that describes the data collection and analytic methodologies for performance measures identified by the state and CMS for inclusion in those reports. The annual report is posted on Indiana's Medicaid website for public access in conjunction with the HIP annual update presentation each year. Next slide. The number of Hoosiers receiving health coverage through HIP is a significant percentage of the population of Indiana. And by comparing HIP enrollment to the population of Indiana as a whole and in comparison to enrollment in all Indiana Medicaid programs, this chart helps to visualize just how many of our friends and neighbors are benefiting from HIP. Based on US Census data, last year HIP members made up 39% of Indiana Medicaid enrollment and 14% of Indiana's population. In 2024 so far, HIP members make up 37.6% of Indiana Medicaid enrollment and 11.5% of Indiana's population. And I wanted to note the enrollment counts on this slide reflect the unduplicated cumulative counts of individuals served for any amount of time during the year. And the counts on the following slides are monthly enrollment counts. So they only reflect the number of individuals who had coverage during that month. Next slide. This graph shows HIP enrollment data over the last 18 months. Enrollment continued to grow from January 2023 through April of 2023, when the return to normal process started and the continuous eligibility requirements in place during the COVID-19 public health emergency expired, which meant that Indiana was required to resume determining eligibility as normal at members' annual redeterminations. As anticipated, we started to see a decrease in enrollment counts in the months following. Pre-pandemic HIP enrollment counts in the first months of 2020 prior to the public health emergency were around 400,000 members. So you can see that as of June 30th, 2024, we still had 696,430 members enrolled in HIP, which is significantly higher than our pre-pandemic enrollment count. Next slide. If you remember from back on slide 4, I talked about the eligibility populations covered by HIP. And this slide shows the number of individuals in the newly eligible population who are served by HIP, meaning this is the number of individuals who wouldn't have been eligible under any Indiana health coverage program prior to HIP expansion. Our newly eligible HIP population has consistently measured over 500,000 individuals throughout the last 12 months. In states like Indiana that have expanded eligibility to adults with income under 138% of the federal poverty level, individuals without dependent children are 6.7% more likely than those in non-expansion states to have a mammogram, and about 5% more likely to be tested for cholesterol, high blood sugar, or diabetes. For individuals with chronic diseases, Medicaid expansion is associated with greater access to and more timely treatment, which means Hoosiers aren't waiting until they experience an emergency before seeking treatment, which in turn reduces uncompensated care costs for Indiana hospitals and clinics. Next slide. Access to health coverage makes people healthier and more financially secure by improving access to preventive and primary care, providing care for serious diseases, preventing premature deaths, and reducing catastrophic out-of-pocket medical costs. This table is a snapshot of some of the utilization metrics we report to CMS in our quarterly monitoring reports. And as you can see from Q1 of this year, our HIP members have benefited from 859,290 preventive and primary care services, 12,824 inpatient admissions, and 3,720,918 prescription refills. Evaluations of HIP over time have shown an increase in the number of adults with health coverage, an increase in the number of adults who have had a routine checkup in the last 12 months, and a decrease in the number of adults who have had an unmet health need due to cost in the previous 12 months. Next slide. And that is all for me today. Thank you for your time and attention, and I look forward to hearing and reading comments from the public.
Thank you, Lynn. We'll pause here, take questions. Before we take questions, there is one area that I'd like to note, which is, of course, we do have the ongoing litigation around the HIP program. We're not able to comment on pending litigation, so I would ask that the committee, we can talk broadly about the status of where that is, but would ask that we refrain from diving into the litigation strategy with Lynn. Representative Shackelford, then Representative Clear.
Okay, thank you for the great update. And I was going to ask about that, but can we get a broad update on where that case is?
Yes, I'm happy to offer that. So this litigation began in 2019, previously called Rose v. Azar, now Rose v. Becerra, challenging a number of aspects of the HIP design, including probably most notable now the power account structure, which is also codified in Indiana law, and the cost sharing. It began in 2019. The litigation was paused during that PHE or public health emergency period, which is why it's sort of come back to the forefront now once we completed the continuous eligibility. The state received a ruling from the DC District Court at the end of June that vacated the 1115 waiver in its entirety. We are pursuing a stay of that decision as well as an appeal of that decision. So technically, the 1115 is not in place right now. We are moving forward, though, of course, as you can see with this special meeting, because we have every hope and understanding that we will either via the litigation or through negotiations with CMS have the 1115 put back into place. So we're going ahead and taking a status quo approach, moving forward with this special meeting and all other typical HIP reporting requirements. So pending decision on our stay request, and then the underlying appeal is kind of the current status of the litigation.
Okay, thank you. And then I just have two questions. The dental rate. I know a lot of dentists were frustrated about this, and dental providers, especially the Medicaid providers, especially in my district, I would say here. What did we land on for that dental rate?
I don't know that number off the top of my head.
I'm happy to jump in. There are actually many dental codes, so it's not a specific number that we could point to say it's X number of dollars. We did go through the typical rate setting process with that group of providers, like our other groups of providers, and it's on our rate matrix. So it's set to be updated on a sort of a 4-year rolling basis. So we will go through that same rate setting process after that. I am happy to provide you that list of rates, but it is voluminous.
Okay, if I can get a summary or a percentage, that would be great.
We're happy to do that. Thank you for that question.
And then the next question would be in regards to the increase, I would say the PHE versus the unwinding. So I'm looking at your information on the chart, and I'm looking at January to May. So I'm seeing about a 16,000 increase during that PHE time. But when I look at the unwinding from June to June 24, about a year, we unwind, it looked like about 100,000 people fell off. So I'm just concerned about how many we actually increased during the PHE and then how many we let go after that. Can you expand on that?
Sure. So the 100,000 decrease might not necessarily be people who have lost coverage. Some of those who are no longer reflected in the data have actually just been moved to a different category that's more appropriate, because during the PHE, we could not reduce coverage to a category that was less robust in its coverage. So many people were staying on HIP because for that reason, they were, no longer eligible, or, maybe they should have been in a different category. So some people still have coverage. It's just they're in a more appropriate category, if that's helpful to know. So,
okay. So can we get that breakdown of people that were just transferred to a lower coverage?
Yes.
Versus, because right now it looks like everybody came out, about 100K came off the books.
Yes.
But if 100K didn't, and some people were just downsized, I would like to get that information.
Sure.
Okay, thank you.
Representative Shackelford, I would just also add, if we put this graph all the way back to 2020 at the start of the PHE, net enrollment has increased even with the unwind period. So we're happy to share that information as well as what enrollment looked like in March of 2020. And if we had that full graph here, you would see that it actually started below the 696. So enrollment did in fact grow even from the net standpoint.
Okay, that would be helpful. Yeah, because I feel like we're just getting a snapshot and we need to look
That's
at the
fair.
whole PHE and thank
It
you.
was- No problem. It was around 400,000 prior to the PHE, if that's helpful to know. So we're up by almost 300,000 as of the end of June.
Okay. All right, thank you.
Representative Clear?
Thank you. I was going to ask about the litigation as well. So thank you for the overview, and Ms. Mong, thanks for your excellent presentation. Lots of good information there. So several questions. The FMAP is status quo, right?
Yes, thank you for that question. It's one that we've received frequently. The 90-10 federal match, the authority for that is derived outside of the waiver. So from a legal standpoint, we feel confident that the 90-10 FMAP has not been disrupted through the litigation.
So the expectation would be that no matter what happens with the pending litigation, Indiana will receive the FMAP for all claims that are submitted until there's movement on the litigation.
That is correct.
Okay. So I'm looking at an Indiana Capitol Chronicle story from July 13th that talks about FSSA saying that it will have to transition more than 335,000 Hoosiers from HIP Plus to HIP Basic. And then it quotes FSSA saying transition beneficiaries will lose access to benefits for dental, vision, chiropractic, bariatric surgery, and TMJ surgery, along with other increased benefits, and will need to start making co-payments for services as received or utilized, even though many members would prefer to make predictable monthly power account contributions rather than scrounge up money for co-payments whenever they happen to visit the doctor or stay in the hospital. So what is the basis for FSSA's assertion that it would have to transition almost half, that's a little less than half of the HIP population from plus to basic?
I will attempt to synthesize what is a pretty weedy, complicated legal argument, and also state that we've outlined this in a public letter that we've sent to CMS that's also posted on our website. So would refer any interested individuals to that, because it goes into a little bit more in depth of an analysis. But at a high level, without the ability to pay the power accounts, the HIP Basic and the HIP Plus structure, really, there is no differentiating factor there. And so when we read what is now the remaining Medicaid state plan provisions, our best interpretation is that those individuals fall into the HIP Basic category, which doesn't have those same added benefits around vision and dental coverage.
Well, there's certainly a difference in terms of benefits, as you just said.
Yes.
So what do you mean there's no differentiation?
Oh, I'm sorry. Without the ability to make the power, since the waiver authorized from a federal standpoint, our ability to collect those power account contributions, without that federal authority, we can't differentiate between the two categories.
Right, but we don't have to collect power account contributions in order to provide those additional benefits.
I'm trying to be careful only because of the pending litigation, but would say it is a requirement in Indiana law that we do. So that's the challenge.
Well, I think you're referring to SEA 165 from 2016, correct?
I'm not sure which legislation authorized it in previous years.
Well, that's the legislation that codified HIP 2.0
Okay.
in 2016. And there's a provision, I don't have it up on my laptop, but there is a provision that gives the secretary authority to make changes based on, I believe it says law or rule. So I would assume that if a federal judge has determined that our 2020 waiver application did not meet the terms of the Medicaid law, then the secretary would have authority to make changes as specified in Indiana statute.
Happy to take that back to the legal team and review that particular line of reasoning. I would just say at this point, our best analysis is really outlined in that letter to CMS and would have to point you there for right now.
Yeah, I just think it's unfortunate, to say the least, to take away those benefits from hundreds of thousands of Hoosiers because of one interpretation of statute, when there certainly is the reasonable opportunity to interpret it differently.
And I should be clear as well that that is what we believe we would have to do if we do not get the waiver reinstated, which is why we are so vehemently pursuing the appeal and the motion to stay, because we do not want to put individuals in that position.
Yeah, I guess I'm talking about what happens if you're unsuccessful in the appeal and the DC Circuit Court judge's opinion stands.
We certainly will have to cross that bridge if and when that happens, and are definitely preparing for eventualities,
Right.
but doing our best to maintain the status quo for the program.
Right. But no one has made a power account contribution in more than 4 years, and the sky hasn't fallen, right?
No one has made a power account contribution since the beginning of the public health emergency. That's correct.
And the sky hasn't fallen.
Not to my knowledge.
Yeah.
Yes.
Well,
There you go. Oh.
I'm not finished. I'll try to be brief, but well, let me just talk about the power account contributions, and I'll end there, and I can follow up as necessary after Senator Yoder. This has come up in discussion before regarding the power account contributions, even when participants, even when members were making power account contributions prior to the public health emergency. It was widely understood that a significant percentage of those contributions, maybe even a majority of those contributions, were being made by third parties, family members, friends, churches, nonprofits, other organizations. I assume you don't have any new information on that, but wouldn't that suggest that after recognizing that, and also recognizing that no one has made a power account contribution in more than 4 years, and based on Ms. Mong's excellent presentation, the program is doing amazing things for more than 700,000 Hoosiers, maybe we should be willing to revisit the discussion about power account contributions, especially if there is a possible statutory interpretation that would allow that under the present circumstances.
I think that's definitely a policy discussion that can take place with the legislature as well, because of the current codification of that. I certainly understand in regards to the differing interpretations. I think that since it's in Indiana code, it would be a broader decision than just the Medicaid agency.
Well, you said earlier that you'd be happy to go back and take another look at the code, but it sounds as though you've already determined the answer. I mean, I'm suggesting that there's an opportunity to revisit the question based on code.
Okay.
And you said a moment ago that you'd be happy to take another look at that, but now you're saying, sounds like you're saying definitively that there is not an opportunity to take another look at that it would require a policy change by the General Assembly. And I'm suggesting that the General Assembly has already given the Secretary the authority to make changes such as this in response to law or rule as specified in statute based on SCA 165/2016.
Thank you for that. I really can't comment any further because of the pending litigation.
Okay.
Senator, I'm sorry, Representative Campbell, I'll get to you next. Okay, Senator Yoder, I forgot.
Thank you so much. And I just want to reiterate what my colleague, Representative Claire, is saying and state an additional statement to urge FSSA and the state of Indiana to prioritize keeping people covered over trying to, what I and many people have said are barriers to coverage. And that's what the power accounts are creating. And the General Assembly, first and foremost, intended to expand health coverage to those who are eligible. And so I encourage FSSA, I stand in agreement with Representative Claire, and it is my hope that the secretary, that we can look at the code and follow the intent of what the legislation was put in place for, and that was to provide coverage. I think it's very important to realize that we are talking about a program that does not cost Indiana anything, but it saves us millions of dollars. I mean, on page 6, we see here what HIP is capable of doing in providing care and the impact that has on the bottom line for Indiana. And yet Indiana is not paying to cover these individuals, and the savings is extraordinary. And these are individuals who, for a single person, cannot make more than, I think it's like $20,000 a year. And for a family of 4, it's $38,000 a year. And what power accounts have done is just create barriers and hurdles and more chances for families, for individuals to be thrown off and to not receive that coverage. That is a huge savings in the big picture for this state. So those are my comments, and I appreciate Representative Claire's comments as well.
Thank you. And just for clarity, I do want to know if you'd like these public comments to be made for the purposes of the record and submission to CMS, would ask that we summarize them again once we get to the public comment part. So I just want to be transparent that if you'd like to restate any of that, then that would be the time to do it.
Thank you.
Thank you, Senator Yoder. Any other discussion?
You mean the?
Yeah,
court
this
report
is Senator
not
Lysing.
Reporting any of this?
Correct.
Can you hear me?
Oh,
I'm sorry.
Senator-
This is Senator Lysing, and I was having trouble with my audio at the sign in, but I have been listening. I do have one question when you have time.
Sure, Senator Lysing, go ahead.
Okay. Do you at Medicaid have a breakdown of how many males you're serving, or what percentage are males, females, or children? Is that available or not? Because there's been some discussion in a neighboring state about the high percentage of males that are being served. I was just curious if we knew that number or percentage.
We definitely do, Senator Lysing, and we're happy to provide that in follow-up. It may even be included on the enrollment dashboard information that's posted to the FSSA website, but if that level of detail is not in those reports, we can absolutely provide that to the committee.
Okay, and how would we receive that information, and when should we look for it?
We can follow up as we send out, we'll take the follow-up items from this and send out to the committee a sort of report out of these particular items. I would say probably a couple weeks. That one is very easy to pull, I would say.
Okay, well, thank you very much, because I think, there's going to be a lot of Medicaid discussion in this next session of the legislature, and we probably need to make sure we understand who's really being served.
Thank you. Representative Clear?
Thank you. Through the magic of technology, I have learned in the last 2 minutes that there was an order on this yesterday.
Oh,
Are you not familiar with that?
you have more up-to-date information than me.
So I have 2 documents. I won't read them in their entirety, but I will at least say what they are. Make sure I have the right dates here. So let's see. The first document is titled Joint Status Report, and talks about the parties requesting that the court stay its opinion and order vacating the Healthy Indiana Plan 2.0 demonstration project pending appeal, except for those portions related to payment or non-payment of power account contributions. Pending resolution of the appeal, issuance of the mandate, and disposition of any timely filed petition for certiorari. And then the second document is an order from, I don't know if I'll pronounce the name correctly, but the Honorable James E. Boasberg, dated August 20, 2024, order granting motion for stay in part and granting joint request for a limited stay. And it specifically addresses the power account contributions. So if you could get some clarity on that from your counsel before the end of this meeting, I think it would be in the public interest to have at least an initial response from FSSA regarding this new information.
We will dig into that. Thank you for letting us know.
Thank you.
Yeah.
So you were not aware that the courts came down with a decision yesterday?
That's correct. I wasn't aware of that particular order. I was aware that we had filed the joint status update with the plaintiffs in this case, requesting the stay. And it sounds like from Representative Claire's reading that the stay was issued. So we'll need to let the legal team dive into that order and as far as next steps.
In part, again, I don't want to misrepresent it because the title of the order is order granting motion for stay in part and granting joint request for a limited stay.
Make a request for Representative Claire to send that out to the committee.
To send it out to the MAC?
Yeah.
Well, I have been receiving all kinds of texts and emails from folks in this room and folks who are joining us online. So I'm getting all sorts of breaking news, but let me see if I can download both of these documents, Representative Garcia Woburn, and I will try to send them out. I think everybody's address is on the meeting email. So if I can reply to all and attach these, I will do that.
Thank you. Okay.
And FSSA will have them as well.
I would appreciate that. Thank you. Okay, great. If we're okay with it, I'd like to move on to the SUD SMI update because there's some great information as that as well. And then we will begin the public comment portion of this presentation. Oh, I apologize. I've missed a couple comments or discussion in the chat, which is Ed Rosenbaum asks about the 2%. This is back on the dental rate question that Representative Shackelford first asked. The 2% annual increase for dental services that is on hold. That's correct. The rate matrix 2% annual indexing is one of the announced FSSA cost containment strategies coming out of the forecast. So those 2% indexing for dental and EMT, there's a handful of other provider types that are listed there on our website are currently paused. Sarah Boslett with Indiana AAP indicates that Indiana AAP is in agreement, appreciative of the healthcare coverage HIP Plus provides for many parents of our patients and supportive of continuing HIP Plus level coverage without barriers. That was in response to Senator Yoder's comments. Okay, great. I'm sorry. Senator, go ahead.
I just have a quick follow-up on that 2% rate increase that's paused. Now, how long is that pause to next budget session till we can cover the decrease that we're having in Medicaid, or how long are they going to be on pause?
We've indicated that the pause will last until that point, at which point we would reevaluate going into the next biennium.
I mean, after session is over?
No, I'm sorry. As part of the budget setting process and the forecast development going into the 2025 legislative session, potential rate changes then would be effective 7/1/25.
7/1/25. Okay, thanks.
Senator Yoder and then Representative Claire.
Just to be clear, I think some of the text of what is going to be circulated from yesterday's ruling, it does state in there that the secretary may make changes to the plan under this chapter if the changes are required by federal law or regulation. And what was in question
That's what I was
was
referring
the
to.
power accounts create barriers, and the federal law is saying the idea, the spirit of the law is that there are no barriers. So I just wanted to make sure that that was clarified.
Thank you. Representative Claire.
Thank you. I did a reply all on the email from Ms. Slade regarding the agenda, but it appears to me that it has a limited number of addresses. So would you please ask her to go ahead and email that out to everyone who is not on the reply all, or maybe better yet, just send it to all MAC members.
Sarah will work on that right now.
I attached both documents.
Okay. The Andrew Sakaris is joining us from our coverage and benefits team, and he will present an update on the SMI and SUD waiver.
Hi, thank you, Cora. My name is Andrew Sakaris III. I am part of the coverage and benefits unit of the Office of Medicaid Policy and Planning, and I will be doing the annual update for the Indiana 1115 demonstration substance use disorder, or SUD, and the serious mental illness SMI waivers. Next slide, please. So just to cover what I'll be covering in this brief presentation is, first I will be going over the SUD waiver. So I'll be going over some metrics that we have, and then following that I'll be covering the SMI waiver. Please keep in mind during this measurement period, this is for the calendar year of 2023 to 2024. There has been some data we have included for 2024, just to give you some context, but we can move on. So I'll be first discussing the substance use disorder waiver. Next slide, please. So in this graph, this indicates the total Medicaid members with a substance use diagnosis who has received medication-assisted treatments or related treatment from 2021 to 2023. As we can see here, there has been an increase of Hoosier Medicaid members with an SUD diagnosis. And when I say Medicaid members, this includes not only HIP, but this includes all Medicaid members, including our fee-for-service members and our members who are covered by a managed care entity. Next slide, please. So in order to help these individuals with a substance use diagnosis, the 1115 waiver grants us the ability to have substance use residential facilities in our state. The Division of Mental Health and Addiction, they certify residential facilities by using the American Society of Addiction Medicine, or ASAM, criteria. So this allows us to evaluate members of when they are coming into a residential facility on what's the most appropriate level of care for them. So within this criteria, individuals are assessed for their level of care at their initial intake. So they can go from from an ASAM level of 1 to all the way to a level 4, which would be considered inpatient. So across the substance use treatment continues to improve year over year in increases of facilities and beds, as we can look at these charts. So right now, currently in Indiana, for ASAM 3.1, we have 13 facilities and 232 beds. For high intensity residential treatments, this is the ASAM level 3.5. We have 64 facilities and 2,904 beds. And we have facilities that are considered ASAM 3.1 and 3.5. Those are 10 facilities, and the total beds for those are 311. And then we can look at the years. We have seen an increase of our number of facilities and also the number of total beds that we're seeing across the state. And when we're looking at our facilities, we are seeing increases in our facilities from every area in our state, whether it's central Indiana, northern Indiana, or southern Indiana. We do know that there are some shortages in some areas. However, we are looking into ways of increasing these facilities. Next slide, please. So to go with the increase of residential treatments, so we can also look at the Medicaid members treated in inpatient and residential institutes of mental disease for a substance use disorder. We have been seeing an increase of members who have been using these facilities. But this is actually a really good thing because members are coming out and they're trying to help with their recovery and they're trying to battle their addictions. So these are actually good. This is a positive step. Next slide, please. And in addition to the increases of individuals going to a substance use residential facility or an inpatient facility if needed, with that, we are also seeing the number of emergency department visits for the substance use care for an acute crisis actually going down. We have been seeing this throughout the years. And how we determine an emergency department stay is for a member who has been in the ER for more than 24 hours. And we have been seeing a decrease of members who have been utilizing the ER for this, which is actually a really good positive thing. And this is one of the goals of the 1115 SUD waiver. So moving on, next slide, please. So now I will be looking at the SMI waiver. These are for individuals who have a serious mental illness or for youths who have a serious emotional disturbance or an SED. So the first slide is we can look at the number of emergency department visits for an acute crisis when it is determined for an individual who has a primary diagnosis of a serious mental illness or a serious emotional disturbance. We have been seeing decreases in these members utilizing the ER, which is actually a really good thing. So next slide, please. So where are these individuals going to? As we can see on this slide, more and more we are seeing patients utilizing inpatient services, whether these are high intensity services that these individuals are using. So these are also a very good thing. So instead of going to the hospital, they are now being referred to an inpatient facility that can treat them at a higher level of care. Next slide, please. And we're also seeing throughout the years from 2021 to 2023, more and more of our Medicaid members are actually using intensive outpatient and or partial hospitalization programs. This is initially, and in particular with the partial hospitalizations, this actually does cover our youth as well, who may have a serious emotional disturbance. Many of our youth are referred to these partial hospitalizations facilities for treatment, and which is actually a very good thing. Next slide, please. In addition to these other services that I talked about, we're also seeing an increase of members also utilizing outpatient services, whether it is going for a psychotherapy session, whether it is for going to a community mental health center for a various number of needs. We are seeing more and more people getting access to mental health service, to behavioral health services in Indiana. And that is one of the great things of our 1115 waiver. That's one of our goals that we had to increase members going for these services, to increase access. So we're seeing an increase of facilities and increase of access to care. And finally, my last slide, conclusion. So we are seeing the increases in the number of substance use disorder residential facilities that have led to decreases in emergency department stays for a substance use disorder acute crisis, increase of access to outpatient clinics and stays in partial hospitalization facilities for individuals with a serious mental illness and serious emotional disturbance have led to decreases in emergency department stays that exceed 24 hours. And last and most importantly, additional conversations around behavioral health and substance use disorder, coupled with the increased access to the institutions for mental disease, IMDs, and residential facilities accessible through the 1115 demonstration waiver, have helped to decrease the stigma and improve options for those seeking assistance in recovery and behavioral health treatment. Thank you very much.
Thanks, Andrew. Great presentation. Senator Yoder.
Thank you so much. This is good to see. I am curious. It does look like it's trending down. And so on page 11, those two intensive and outpatient. What do you think? Is that a permanent trending down? I'm concerned about that because I imagine the rates of substance use disorders would probably be going up or at least staying the same. But what do you speak to both of these trends?
So what we're looking at for the for individuals with a serious mental illness or a serious emotional disturbance, we seeing the trends going down, but however, we should note that for intensive outpatient partial hospitalizations, these are for individuals who are in crises. So with more access to care, more access to outpatient services, those services will be going down. Which is actually a good thing because more and more people will have access to care. They'll have more access to outpatient services. And then if there is a need for an access, crisis access, we can afford them to that.
Do you know how many beds Indiana? I mean, I'm sure we know how many beds are available in the state. Do you?
Currently we do know for the for when it comes to substance use residential facilities, right now we do have 3,447 total beds for substance use residential facilities. For individuals with a serious mental illness, we can get you that data.
How many? So that's how many we have. How many do we need? Is there a way for states to know how many we need and what the difference is?
Unfortunately, I think that is a very hard question because we can look at the different trends though, but it's also we have to look at, how are we as a state looking into how do we battle substance use disorder? We have been seeing great things, across a number of years with the talking about your stigma, decreasing the stigma campaigns that we have been seeing in the state, know your facts and things like that. So I think if we see more of those campaigns, more of that jointed effort with the government and our MCEs, with our facilities and even communities coming together to talk about these important issues, we can begin to see a more positive trend in helping these individuals.
I would like to see the bed number for mental health facilities. That would be helpful. And one more question. Can you speak to, since we are talking about, in this case, the 3,400 plus beds for substance use disorders, are those equitably distributed throughout the state? I mean, are there sections of Indiana that you have to leave your community to get help or somehow find transportation?
Yes, we are seeing that in some areas of the state. We are in talks with the Division of Mental Health and Addiction to make this more equitable. This is something that we have been seeing in the data. However, though, this is something that we're looking at because the other issue we are also seeing that in Indiana, we are seeing this urban and rural divide. And now there is a positive thing that we are seeing that can actually help these individuals with the rollout of the mobile crisis units. This is actually a wonderful thing to help these individuals to get more access to care. And we are seeing more and more of these units being designated by DMHA and being rolled out. So we are seeing continued trends in this way.
Well, I just think it's very important for members or for people to stay connected to family, to their communities, and knowing how many beds are available county by county or regionally would be helpful.
Yeah, this is something that we have been looking into. This has been an issue because the other thing to
We've had a,
Uh-oh.
sorry, we had a Zoom issue here.
I don't like it when FSSA says, uh-oh.
It's
It
just
never
me. I
ends
say it
well.
20 times a day.
Um,
Sorry, go ahead, Representative Clear.
Thank you for your excellent presentation as well. I think there may be some confusion though. So you were reporting on the SUD and SMI waivers.
Yes, correct.
The post-award.
Yes.
Blah, blah, blah. Yeah. But on your first two slides and your last slide, you still have the HIP stamp on there.
Mhm.
But those two waivers are separate and distinct from HIP.
Yes, they are.
Right. So we're talking here about three separate and distinct 11,
Correct.
15 waivers,
Correct.
HIP, SUD, and SMI.
Yes.
Okay, thank you. I want to tie back though from your presentation to Ms. Mong's presentation. I believe it was her slide 10. And I meant to ask this question before, Ms. Mong, but you gave some information, provided some information that wasn't in your slide 10, talking about the improved outcomes of HIP 2.0 members. And I think you talked about how it reduces reliance on acute care. I don't know if that's the exact term you used, but I think one of the really important points that needs to be part of this discussion is the extent to which HIP 2.0 is playing a critical role in access to behavioral health. So can either of you speak to that and talk about the relationship of these waivers, specifically the number of HIP 2.0 members who are receiving behavioral health services through HIP 2.0, because I want us to be very cognizant of the potential consequences for that population.
And if that's not data we have right now, we could pull that. I think, Andrew, is it fair to state that the information you've provided is across the entirety of the Medicaid population?
Correct.
But we could definitely stratify that and isolate on the HIP 2.0 side some of those same data points, if that would be helpful.
Sure, and that's a good point, that what you were talking about is across the entire Medicaid population, that these, for lack of a better term, all of our waivers in the context of behavioral health are interwoven.
Correct.
Is that a fair term?
Correct. Because it's important to note with the SUD and SMI waivers, for HIP 2.0, we do have those age restrictions for adults, but for the SMI and SUD waivers, we do cover not only individuals who would be part of the adult population would be maybe covered by HIP, but we also do cover youth in our facilities. And also we do cover those individuals who are duly eligible for Medicaid and for Medicare. That's also part of our data as well.
The dual eligibles,
Yes.
right.
So the populations for the SUD and SMI waivers are based on diagnosis rather than, the other eligibility factors that we consider for HIP.
Right. But without having the advantage of statistics or data based on your knowledge and experience, both of you, is it fair to say that HIP 2.0 is playing a very significant role in access to behavioral health services in Indiana?
It's a hard question to answer, to specify just for HIP, since we do have this waiver. But I mean, in general, HIP helps with access to care, so I would have to say yes. Having HIP 2.0 does improve access to behavioral health.
Well, thank you. And sorry to put you on the spot, but I think it would be very helpful to have data on this, especially as we continue the discussion around the future of HIP 2.0. I think our next meeting is November. Is that right?
That's correct.
So that would be very timely, since the legislative session starts in January. And I know there are a lot of other folks who are interested in this as well. Thank you.
Thank you, Representative Garcia Wilburn.
Yeah, thank you, Andrew, for this presentation, data, et cetera. I think it speaks a lot to the upstream approaches that we're also trying to pursue here in Indiana that are helping stabilize the inpatient needs. I think I just, number one, have a question about the clarity of the data. On page 8, slide 15, when you talk about total Medicaid members with SUD, are you specifically only diagnosed or using the SUD diagnosis for those receiving MAD, which is what I'm seeing here, right? Medication assisted therapy.
So for this one, the total Medicaid members with substance use diagnosis is not only for people who have received MAT services, but also a related treatment. So it's either one of the, again, it can be both or it can be one of the other.
Good. So it can be both or one or the other. My next question is regarding youth treatment, and I'm encouraged to know that some of these facilities accept youth. How many?
We can look into that for you to find out more specifically. We do have some parameters around these facilities. It is important to note that when it comes to partial hospitalization facilities, especially for youth, these are also being licensed by DCS. So we would have to also work with them as well. Well, we can get you that data.
Yeah, would love that data because I think we're missing a population. I mean, we made national headlines that Indianapolis is a hotspot for youth overdoses. So it would be really important to know what that treatment number of beds is.
It should be noted that for youth, they do have access to various forms of treatment that is actually very age appropriate for them. For example, intensive outpatient treatment is available to youth, whether it is, and we do make sure that it is age appropriate for them. However, we are still, we can look at the data for, let's say in Indianapolis on where are these facilities located to make sure that there is adequate access for them.
Yeah, I appreciate that comment, but a concern I do hear from my constituents most regularly with parents of children with substance use disorder is that they have to send them out of the state.
Yeah.
Thank you. Representative Karakoff.
Slide 18, page 9. I'm trying to understand the emergency department visits. Like there's a substantial, almost, very high increase between February and March every year in emergency room visits. And then there's this, decline, a kind of a gentle climb. And then as the weather tapers off into the fall, there's this decline. There must be is it seasonal? What causes that spike between February and March? And then how does it go down? It just doesn't make sense to me. You would think there would be either a gradual decline. Why the big, delta in emergency room visits?
It's a great question, Representative Karakoff. I don't know that we've dug into the exact causes, but I think it is definitely a seasonality effect. And I think it's something worth exploring with our DMHA partners in the mental health and addiction division to say, are there things we can be doing to sort of anticipate that?
That's huge. And it's year after year after year.
It's a great point.
I bet get pounded on Super Bowl weekend or something. I mean, something's going on that's societal, I think.
Thank you. At this point, I think just to keep things moving, we will move on to the public comment section of the special meeting. And so I will give our court reporter a moment. Are we ready? Okay, great. So if you're going to be offering public comment, if you're a committee member in the room, we have already have your name and how to spell it. If you are coming up and we have one individual signed in, please do state and spell your name for the record. That will assist our court reporter. If you are watching via the YouTube live stream, this is the information for how to submit public comment to be included in this update. So with that, we'll start with the committee and then we'll move to the public. So Senator Yoder.
Thank you. I'll just repeat what I said earlier. I want to urge, based on what we are hearing, based on yesterday's information ruling, that I urge FSSA and the state of Indiana to prioritize keeping people covered over trying to keep barriers in place and barriers to access, which is what we are hearing that the CMS is saying, that power accounts are barriers to care. And the General Assembly, first and foremost, intended to expand health coverage to those who are eligible. And it is my hope that we do away with those barriers and provide the coverage to those who are eligible, full coverage.
Thank you. Senator Cadora.
Thank you, Cora. My understanding is that the administrative cost of collecting the power accounts is more disadvantageous to the state than actually getting rid of the power accounts for constituents and patients. So it is my recommendation, based on my constituents' needs in my district, to urge FSSA to support the position of eliminating the power accounts completely. The few dollars that are being charged for those who are in the Power Plus do not significantly, I have not seen studies that have significantly shown a strong correlation of improved health with the few dollars that they pay. But it does impact communities and families with low income. And I think that probably the state would save much more by enhancing access to healthcare rather than imposing the fees, the power account fees. And similar to what my colleagues have commented, if we were able to survive without charging the power accounts for the last couple of years, then I urge us to continue as a state and as an agency to find ways to completely remove the power accounts instead of keeping them. Thank you.
Representative Claire.
Thank you. I don't want to repeat everything I said earlier. I would echo much of what my colleagues have said. And Senator Cadora, thank you for reiterating my point about the fact that no one has made a power account contribution for more than 4 years, and the sky hasn't fallen. With that in mind, I think it is time to revisit the original policy argument for power accounts, recognizing that, to my knowledge, there is no data whatsoever suggesting that power accounts have led to improved outcomes. And I think our focus in the design of the Medicaid program broadly and in the design of HIP 2.0 specifically should be to improve outcomes, outcomes for individuals, and to improve Indiana's population health. So I think it's time to revisit that discussion. I think it could be a very constructive discussion. I have suggested other ways that members, participants in HIP 2.0 might be able to demonstrate what we've talked about as personal responsibility in the past. I think our definition of personal responsibility has been focused too narrowly on financial contributions, and it fails to recognize many of the realities of the covered population. With that in mind, there are other things we could do that would be much more effective in helping members of the covered population attain self-sufficiency, which is what I think we should really be talking about, self-sufficiency and empowerment, including economic empowerment. There are a lot of folks who are receiving access to health services as a result of HIP 2.0 who would love to get to a point where they no longer qualify for HIP 2.0 or for any other Medicaid program. They would love to have the tools to accomplish that, and we as policymakers and working with the executive branch, I think, should endeavor to provide such tools. So it's a bigger discussion than we have time to have here today, but there are lots of ways for people to demonstrate personal responsibility, and I think many, if not most, members of the covered population already demonstrate personal responsibility in very meaningful ways. And we have the ability, I'm speaking as a member of the General Assembly, we as policymakers have the ability to provide them with tools that could lead to more self-sufficiency and economic empowerment. With respect, I'll close by saying, with respect to the current litigation, again, I won't repeat everything I said earlier, but I do have the legislation in front of me now. So I went to the IGA website and pulled up the latest version of SEA 165 from the 2016 legislative session. And I'm looking at the bottom of page 22 of that latest version, which is the final version of the legislation that was signed into law. It says the secretary may make changes to the plan under this chapter if the changes are required by federal law or regulation. I'm not an attorney, so I will certainly defer to the attorneys, but I would challenge FSSA to look for ways to interpret the 2016, the statute resulting from the 2016 legislation that will allow HIP 2.0, including both HIP Plus and HIP Basic, to continue without power account contributions until the legislature has an opportunity to revisit the issue. Thank you.
Additional comment from the committee, Representative Shackelford.
Thank you. I just want to know, where did you say we can send our written comment against the power accounts? Because I'll just send a memo in writing.
Here's the information, and we'll be sure to circulate the slides right afterwards.
Okay, thank you.
Senator Yoder?
I wanted to make one other comment, that at a time when the state is looking at a real budget shortage when it comes to our Medicaid dollars, our HIP expansion program costs Indiana nothing. The only thing that it costs us is the administrative costs of actually trying to administer the power accounts. So while it's not costing us and it saves the state so much money, it does cost us in administrative costs to try to uphold a program that actually just creates barriers to people who are eligible for healthcare. And I just wanted to make that point, since it seems that most of our conversations are how we can save money about, when it comes to Medicaid dollars. And here is one way that we can actually save money and do right by Hoosiers. Those are my comments.
Thank you. Representative Campbell.
I just want to kind of piggyback on Senator Yoder's comments about when we make an investment, and this is a good investment. We're taking federal dollars and having to administer them, but 39% of our households in Indiana are not making a living wage, not able to go out and buy their own health care. And one illness, everybody's one illness away from complete devastation. This is an opportunity for the state to invest in its population, and it saves, like Senator Yoder said, it saves us money in the long run to not pile on this additional medical expense onto families that just cannot afford it. When you do early intervention, we know it saves dollars. As we can see with our substance use disorder investment, we are decreasing the funds that we need to spend. So I would just encourage the state to take that into consideration as we move forward to make sure that we are continuing to help these families. Thank you.
Thank you. And with that, I think public comment from the public or non-committee members. We have Tracy Hutchings-Getz from Hoosier Action.
Hello, good morning. I have also submitted my public comment via writing, so hopefully y'all have received that as well and it's helpful. My name is Tracy Hutchings-Getz, TRACEYHUTCHINGS-GOETZ. I am the Communications and Policy Director of Hoosier Action. We're a grassroots community organization dedicated to improving the lives of everyday Hoosiers and rooted in rural and small town Southern Indiana. Since our founding in 2017, Hoosier Action has held thousands of conversations with Hoosiers about their experiences of HIP, and many of our members are enrolled in HIP. Drawing from these conversations, my comments today emphasize the vital importance of HIP for Hoosiers and for our state's economy. And we urge FSSA to take the opportunity afforded by the recent ruling in the Rose v. Becerra federal lawsuit to improve HIP coverage and reduce administrative costs by ending power account payments and granting all HIP members HIP Plus. For our members and hundreds of thousands of Hoosiers across the state, HIP ensures that they are able to get and afford the essential healthcare we all need to live, work, and take care of our families. When I think of the significance of HIP, I think of people like Eva, a single working mom of 3 and a HIP member who experienced severe abdominal pain, and she only went to the emergency room because she knew she was covered by HIP. She ended up needing an emergency appendectomy. Had she delayed her care, it could have been devastating. For the past 4 years, HIP ran successfully without power accounts. And during this period, my organization contacted and surveyed more than 40,000 low-income Hoosiers. And we heard significantly fewer concerns about the program during this period when all HIP members were enrolled in HIP Plus and not subject to power account payments. HIP Plus has always been the initial default benefits package for HIP members, and HIP Basic, according to the state's own website, is, quote, the fallback option. The Rose v. Becerra lawsuit is an opportunity to enshrine positive changes in HIP made during the pandemic. Ending power account payments and enrolling all HIP members in HIP Plus would not only improve coverage, it would also reduce administrative costs. A 2022 evaluation of HIP found that it is cheaper to administer the program without burdensome barriers like power account payments. Quote, despite a 25.6% increase in covered members during the first few years of the pandemic, because the administrative burden of the MCEs was reduced as operations such as prior authorizations and the collection of monthly contributions were suspended during the COVID-19 PHE, total administrative costs stayed stable, even as enrollment increased due to the COVID-19 PHE. It is well documented that Medicaid enrollment churn due to cost sharing like power accounts actually drives up administrative costs. Re-enrolling Medicaid eligible Hoosiers who have been disenrolled for reasons such as missed power account payments is a process known as churn. It has been estimated to cost as much as $400 to $600 per churn in Indiana. If you multiply that by the number of people who churn in a year, which can be as many as 40 or 60,000 HIP members who lose coverage due to power account payments, the costs become significant in the millions of dollars. Churning also increases Medicaid expenditures when eligible Hoosiers who have been disenrolled and then re-enroll in Medicaid as they obtain high-cost care in hospitals that would have been avoided had they had ongoing care. HIP is an essential part of Indiana's health and economic infrastructure. Just like our roads and our bridges, HIP ensures Hoosiers can go to work, young people can pursue their dreams and go to school, and parents can take care of their families. HIP also brings in $4 billion of federal funds into our state, funds that are spent at the local levels, going to rural hospitals, to doctors, and towards maintaining our healthcare workforce. Thank you.
Thank you. All right, and that concludes our public comment. So we will close that portion of the meeting. Thank you for those that commented, and thank you to our court reporter. And we can continue on with the regular meeting now at this point. Okay, pivoting a bit, the next topic, and I am going to try to keep us on time check a little bit more because we have two great presentations, pathways, but the Certified Community Behavioral Health Clinic I think is very important, and I want this committee to have an opportunity to hear that as well. So if we could try to keep pathways to a 30-minute presentation and discussion, and then we'll do the CCBHC, we'll go a little past and go 12 to 12:30 on that. I would really appreciate it. Okay, and I'm sorry, I will introduce Holly Cunningham Piggott, who is our Director of Care Programs and is going to provide us a pathway update. Sorry.
Hello, I'm the Director of Care Programs and I directly oversee the new Pathways program that launched July 1st, 2024. Just a quick kind of overview of what Pathways is. It's our managed Medicaid program for individuals 60 years and older that are eligible for Medicaid. The Pathways program was designed to work in conjunction with individuals also receiving Medicare benefits and for individuals that also receive long-term services and supports such as nursing home services in a nursing facility or individuals that receive home and community-based services. So we back in, gosh, now I can't even remember, 2023 awarded 3 health plans the contract for Pathways. That was Anthem, Humana, and United Healthcare. And so with those managed care entities, which we refer to as MCEs, and individuals were assigned or they picked which one of those health plans they wanted to enroll with. Going forward now, members will receive a notice 60 to 90 days prior to transitioning to Pathways of the MCEs they can pick from. If they don't choose an MCE prior to the go live of their enrollment date, then an MCE will be auto assigned. The individuals have up until the go live date or the transition date, enrollment date for them to change their MCE, and then they have 90 days after that enrollment date to also pick another MCE to enroll with. There's other opportunities for them as well, and that would be during their annual redetermination date, during the Medicare annual enrollment period. Anytime the Medicaid or Medicare plans become unaligned, they can also change MCEs, and then there's just cause. So, you know, maybe they have issues with quality or they have their provider has changed, is no longer contracting with the MCE that they're currently enrolled with. Next slide. So now that we are officially live and in process, we wanted to continue to ensure that our MCEs and other Pathways vendors are meeting the state's expectations of this program. So we've implemented some post go live monitoring processes. So like before we went live, we had the whole readiness. You had to show readiness that you could take new members come July 1. We've decided to like extend that out another year and call it our post live kind of readiness. And so we've put the same kind of schedule in place that we did for readiness. And now we're really looking at the things that they showed us in readiness, but in the live environment. You know, most of the time when they are showing these things, it's policies they wrote, you know, anticipating or things that could happen or processes that they need to put in place. And now that we're in the real live environment, we need to see that those things are really working. We also have been doing things like secret shopper and calling our MCEs. We've got a vendor, which I'm going to talk about in a minute here, the member support services vendor. We've been doing secret shopper calls with them. We've done kind of on the site audits of the MCEs where we just tell them we're coming and we sit and listen to customer service calls, or we sit and listen to care manager calls so that we can really ensure that our MCEs understand the program and that they understand how to implement the program to everybody's individual needs. So our member support services vendor is with Maximus, and this is an independent resource that we've made available outside of the MCEs to our Pathways members. So our Pathways members can call our MSS, which that is our acronym for our member support services program. They can call MSS, and it adds another layer of support and oversight that we have in place for the Pathways program. They provide members and authorized representatives with education, advocacy, and support to navigate and resolve issues. They educate members on what is managed care and how to access services. They assist members that are experiencing issues in accessing care. They also are a big part of helping file grievances and appeals, and then helping the member follow up with those grievances and appeals. They've been a great resource for us because having this third party is kind of this independent that can report issues that they're seeing or experiencing with the people that call in, and then we can kind of quickly turn those around and address the issues with the MCEs. So part of what the, as I mentioned before, like the identifying issues that individuals and members may have with their MCE, the MSS vendor has developed relationships with the MCEs, and we have an escalation process. So they have a main point of contact with each MCE. So anytime there's an issue that needs some sort of urgent response, then they have a direct line with the MCE to escalate those issues. What we saw in the first 45 days as the top reasons our individuals in Pathways called our MSS vendor was they needed help figuring out who their care and service coordinators were. They had requests for medical supplies or transportation or meals. They needed help understanding how they get their home health care services in place, and then pharmacy inquiries. This diagram also is a just a visual of the our managed care oversight that we are doing post go live with Pathways. So one of the first things that we put in place was go live reporting. So we have the MCE submitting weekly reports for us to review. Some of those reports include claims payment reporting, the call center. So the MCE's provider and member call center stats. They report out to that weekly to us. They are reporting to us prior authorization denials for home health care services. They are reporting out to us the completion of assessments, and then we have some monthly regulatory reports that they are also sending to us. We get them weekly, but then they also have to give us monthly ones. We are doing what I talked about earlier, this on-site and desk review audit, which is really just an extension of kind of what we had put in place for readiness. And so we are listening to calls. We are checking on to make sure that they've done continuity of care. So that would be loading the files that we gave them on prior authorizations, or the files that we gave them on service plan authorizations for the waiver. And then we're continuing this our MCE interaction and oversight. So we have daily stand-up calls with the MCEs every morning. We are continuing to solicit feedback from our stakeholders so that we can share their experiences with the MCEs. We are continuing to monitor their provider network development through a monthly check-in. And then we also have weekly meetings with our quality team in the MCEs and our clinical teams in the MCEs. So we are staying pretty close in touch with the MCEs through this implementation process. Some of the reporting I was just talking about, this is the member helpline stats that they report out weekly. So this goes, actually, I pulled in all the data from July 1 from the go live enrollment date to August the 17th. The MCEs are receiving thousands of calls per week. And as you can see there, that their metric is that they have to answer 85% or more calls live within 30 seconds. And they're all three meeting that metric. They also have a metric that they have to have less than 5% abandonment calls, and they are also meeting that metric. And we have similarly, then we also have the provider helpline. And I did just skip over, but that we have some, real quick, top member call reasons are really care coordination and clinical support needs, questions regarding benefits and covered services, help finding a provider, and then, what is their eligibility and ID card requests. But likewise, we also have the provider helpline. And again, they're receiving less calls, but we're still from July 1 to August 17th in the thousands. And they have the same metrics, 85% or higher. They have to answer live within 30 seconds, and they are meeting that metric. And then the abandonment has to be less than 5%, and they're meeting that metric as well. Our top call reasons for providers are claims inquiries and claim status, authorization statuses, benefits and coverage questions, and then member eligibility verification. We also implemented a pathways issue resolution tracker. So we have a general email box, which is up on the slide, Indiana Pathways at fssa.in.gov. So in partnership with all of our associations and then information we have gotten out into the community with members and with providers, they can send any issues, or if they come through, they may call us as well. They don't have to just send it through there, but we take every issue and we log it into a tracker. Then along with our MCE partners, we work then to resolve those issues. And basically, my team, we review the issues tracker daily, and then outstanding items that we get with the MCEs to make sure that they're doing follow-up. We have logged over 400 issues to date, and we have closed over 300 of those issues. And we will continue to use this process until we feel comfortable that it's not needed. The other way that issues can be resolved is they can go directly to the MCE, and we've put the MCE's information on the slide as well. So we've, I mentioned earlier that one of our weekly oversight methods is that the MCs have to submit a claims payment report. And so we are monitoring this report very closely. I know that this was a huge anxiety for our provider partners that are participating in pathways or that are IHCP attested providers. And we review, the reports come in every Monday. We review them on Tuesday, and then we usually address our concerns with our MCE partners in our stand-up meetings on Wednesdays and Thursdays. There are two different types of claims that can come in. There's the CMS 1500, which is also the professional claim. And then there's the institutional claim, which is the UB04. Part of the claims monitoring then is that they have to break down what they've paid per each of those claim types, and then provide us with the top 20 denial code reasons. Part of our claims monitoring as well includes our claims advisory work group that was outlined in Senate Bill 132. Yeah. And so with our claims advisory work group, we have different provider types that are on our group, and we meet every other week at this point. And basically we run by them some of the issues that we've come across, how's the best way to resolve it, but they also come to us with, here's things that we're seeing. And we're able to take that feedback, work with the MCEs, and either quickly turn around solutions, put in some workarounds that then get those payments reprocessed or claims reprocessed, or we provide education. We will get out, bulletins right away, or the MCEs will hold some open office hours to help address some of those concerns. So I talked about some of the billing denial reasons. So the UB04 is the institutional claim, which is really used by our nursing home providers and then our other institutional Medicaid providers. But we also have then the professional claims, which is the 1,500, and it's used primarily by the waiver providers. What we were seeing as some of the top denial reasons were providers using the wrong provider ID, or for waiver, you have to use your LPI instead of your NPI, which is when you do billing. And so if they use the NPI when they build waiver services, that was creating an issue. We've seen a lot of duplicate claims submitted. So providers may submit a claim and then they don't realize they've submitted the claim, or they don't think the claim's gone through, and then they submitted it again. We've had some issues with providers matching their electronic visit verification reporting. So EVV was a CMS requirement, and it had a hard launch July 1 along with Pathways. So we had providers really trying to get into the groove and making sure that they are aligning with their EVV reporting. And then we have denials of services that aren't covered. This next slide is just kind of a quick summary of our latest weekly report on claims. We have seen that we have seen an increase in the percentage of paid claims since July 1. And so we still have work to do. There's no doubt about it. And we really lean on our provider claims advisory work group to help us with some of these things. And we are working with the MCEs diligently as well. But we've quickly increased over the last 8 weeks, I would say, the percent of paid claims. And so this is where we're at right now by MCE. As you can see, though, all the percent of adjudicated claims paid within 21 days, the MCEs are hitting that metric. They, for the most part, have to have adjudicated claims paid within 98% of those paid within 21 days. And so they are meeting that metric. But again, we have some work to do. We are working diligently. Like I said, we have lots of things in place to help us identify what some of those issues are. Some of the things that we identified quickly was that the waiver providers who also had an NPI and an LPI were billing with their NPI, and that in the billing world would be a denial. But in the Gainwell world, they had put a workaround, and we weren't aware of this. So they were crosswalking these and behind the scenes. So we got with the MCEs. The MCEs are now paying, whether they submit it with their LPI or NPI. Now they're paying those claims because they are now doing a crosswalk behind the scenes. We have found that there was some services that would require a Medicare CO explanation of benefits, sorry, these acronyms, explanation of benefits that needed to come along with the claim. And we recognized right away that there were some Medicaid billing codes that shouldn't go through Medicare first. And so the MCEs were able to regroup and configure their systems to fix that. So we're seeing a lot, and when that happens, we're seeing lots of those then claims reprocess. We don't send it back to the provider and say, please resubmit. We just pull those back in, and then they reprocess them. The last thing I think I really will touch on very quickly here is our, as part of the Senate bill that put in place the claims advisory work group, we also had to put in place a temporary emergency financial assistance program. And so we have, this is in place today. We have had providers applying for this assistance. They had to be eligible for this assistance. They had to successfully complete the Pathways claims testing process, which we had in place from the end of April through the beginning of June. There was over 2,500 providers who did participate in the testing with the 3 MCEs. And you can find the list of providers who successfully tested on our website, and there's a link in the slide. We have received and processed over 165 applications for temporary emergency financial assistance. And what has, even if the provider did not participate in claims testing, we are still reaching out to those providers. Just because we might deny the application because they didn't participate doesn't mean we aren't still reaching out to them, having the MCEs reach out to them and provide assistance to get their claims processed. Did you want to add anything to that? Okay. And so just the last couple of last slide is just some where you can find some FAQs on Pathways and the Pathways website.
Senator Fedora, then Representative Campbell.
Thank you. I appreciate the presentation. I'll be direct. On July 1st, the agency issued a press release with some data on the wait list. Specifically, I'm looking at it, Pathways for Aging, 39,842 slots, of which 29,268 were filled. So as of July 1st, only 10,574 slots were available. Do you have an updated number? Since July 1st has been almost a month and a half to 2 months. How many open slots do we currently have, and how many people are on the wait list?
I do have that data. Let me pull that up. One thing I do want to note on the outset, thanks for the question, Senator Fedora, is we have been trying to take the opportunity to state, and I know you're well aware of this, that the Pathways waiver is a part of, but also separate from the Pathways program. So we do want, for those that may be listening in, everyone to be clear on the fact that there is no wait list to enter the Pathways program. You are correct, though, that the Pathways waiver is sort of the new branding around what was previously the aged and disabled waiver. So with that in mind, we yesterday launched a new website with waiver waiting list information that includes a static dashboard around the number of individuals we are inviting each month onto both the Pathways waiver from the wait list and the health and wellness waiver from that wait list. And so it divides up. There are priority categories, that have, if you are being discharged from a nursing facility, for example, you're a priority category and go to the front of that invitation list for the waiver. So it breaks down each of those categories so that from a transparency standpoint, people can see how many individuals we've invited off. Let me just pull up really quickly the specific data.
And do you mind sharing the website publicly so that we can?
Yes, happy to do
Is
that.
that on FSSA's webpage or website?
It is. It is under both the OMPP and DDRS tabs of FSSA's website, but we're happy to send that out so that it's easily accessible, and we'll reflect it in the minutes for next time as well. I'm happy to follow up with this information in just a moment if you would bear with me while I pull it up.
Sure. For the sake of time, I'll ask my other questions. But I think the concern continues to be around the wait list, and I understand the dynamics of people moving and getting reclassified in different programs, and that impacts that. I think for the public knowledge, I think it's important to know that I'm not sure if it was misinformation or if it was not clearly articulated. While some people think it is true that CMS has to approve the number of slots, but really it is also influenced by decisions made at the state level, budgetary numbers, because the Medicaid program is a match between the federal government and the state as far as contributions. So the projections of the aging population plus the budgetary concerns are the numbers that get submitted to CMS to approve. So it's not that CMS forces the state of Indiana to come up with one figure annual and say, here's the figure that you can have and only the figure. It's really a partnership between the state and CMS to determine what that number is. So I shared that to say that there's a responsibility on us as legislators and the General Assembly during the budget session to use this data to be sure if there's more money needed to expand services under the waiver for the pathway waiver specifically, then that becomes more of a fiscal policy decision on our side to do. My second question is in regards to claims. I think you did a really good job presenting the data on the claims. I just want to reiterate that I'm hearing constantly as recent as 3 p.m. yesterday from providers in the community that are extremely frustrated. There are two concerns. One, cash flow. Before the pathways launch, they used to get paid, some of them on a weekly basis, some of them on a monthly basis. They are seeing 2 to 3 week delay in payments to the point that some of them are considering getting out of the business because of cash flow and payroll issues. So that's one. And then the second issue is that they are frustrated with the MCE's implementation. So two MCEs tend to have, I think, one payment portal that they use, and one MCE has their own. So even those who share the same portal, when they submit data, they check if the person first is eligible on the using FSSA's data, and the FSSA is saying, yes, this person is eligible. But when they submit a claim, they get denied. And they said that this person is not eligible. So that was direct feedback that I've heard yesterday from one of the providers that said it's extremely frustrating that even the MCEs in some instances they don't know what they're doing. So I'm comforted to know that you are paying attention to this critical report, you're monitoring it, and you're working on it on a daily basis. My advocacy is on behalf of patients, but if the providers are not getting paid, then patients will be impacted. That's the genesis of that. The last thing I want to share, that same press release on July 1st indicated that under the pathways waiver, 800 individuals will be processed per month. I'm getting reports, and these are not, I did not do a statewide survey, but the emails that I'm receiving are indicating that the number of folks who are being processed is about 200 rather than, or in the range of 200. Can you confirm if you are still aiming to process 800 people on a monthly basis, and where we are on that? I know it's been less than 2 months since the launch of the program, but.
Sure, and I can also answer, thanks, Senator Fedora. I can also answer the other question. Currently on the health and wellness wait list, the number is 4,431. On the pathways wait list, 9,247 are the more updated numbers since that July 1st press release. This dashboard that I referenced earlier outlines the number of invitations that went out each month. And so for July, for the pathways waiver, that was 856 invitations. And for August, that was 872. So we are trying to catch up for those that decline actually coming onto the waiver or have moved out of state, et cetera. We are adding those invitations back in because we are working to expedite the process to the extent possible. To the comment around how many we are processing, there are differing inputs, of course, the Medicaid financial eligibility, the work that the AAAs do around determining the level of care and that piece is met, and then the actual placing onto the waiver. So we are continuing to gather data around what's the average time from the time of the invitation to when the individual is actually enrolled. It is very case specific. If I'm already on Medicaid and I've already had my level of care assessment, I can be translated into the waiver very quickly from the time of my invitation. If I haven't taken those steps, it may be longer. So I don't want to say that it's not. We have extended 1,728 invitations in July and August.
And I appreciate that you're trying to stick to what you said initially, which is 800 a month. But I think at that rate with 800 a month, if the wait list is almost 9,000, you're looking at 12 months a year. Now, I do understand the Pathways program, folks are still eligible for some Medicaid level services. But to get into the Pathways waiver specifically, that means that we have 12 months. So I think we have 4 months left to the budget cycle. And I think if there's a capacity issue within FSS, I understand the logistics of processing the different buckets of eligibility and going through the process. But I think, if you put yourself in our shoes as legislators, again, as a former FSSA employee, I understand what you're doing. But as a legislator, when I go to my community and say, we have a wait list of 9,000 people on the waiver, and it's going to take 12 months to process them, it's really difficult for us to explain that to our constituents. So I urge you to do everything in your capacity to help with that. And here's a concluding thought. Yesterday, I got 2 emails specifically for 2 cases of 2 patients. And normally what I like to do, some of them even reach out to me from different districts that I refer them to their own state senator to reach out to FSSA with the social security numbers and so on to help with these cases. A couple in their 90s in Evansville, Indiana, they used to live together, a couple, married couple for over 40 years married together. And the FSSA used to pay approximately for the housing needs under assisted living, about $3,000 a month. With the rollout of this program, they got separated. And now they are being put back together in not a private apartment or private assisted living place, but shared with others. So they're not husband and wife together. FSSA is currently paying $6,000 to $7,000 a month instead of $3,000 to keep them together. They had to get rid of their dog because now they're no longer in a private space. Those two individuals happened to reach out to me from Senator Vanita Becker's district. I referred them to Senator Becker to reach out to FSSA with the specific details. This morning, I got another email from somebody else who said, I'm the caregiver for my brother, 63 years old, who had a stroke. And I was told by my AAA agency that you're not a priority. And I don't understand this whole priority, which you referenced a little bit earlier. So SECOA is the AAA for that person that lives in my district. And they were told that they're not a priority. And that's why they will be pushed not to the front of the line, but to the back of the line of the wait list. So the constituent is asking me, where's transparency? And who, if SECOA can't explain priorities, then who else can explain that to me? And does my brother deserve the services that they need or not? So please understand that we are under immense pressure by our constituents to find answers and responses to real life cases that the data that you presented on that presentation might not fully articulate the human need of these individuals who are living under extreme anxiety. Last meeting, I shared with you those who had to deplete their funds to get to qualify, and now they are being put on the wait list. I do understand they qualify for the program, but not, and they're on the wait list for the waiver. But if I've ever understood anything, the more that I age, the more that I understand that one of the most critical things to humans that they desperately care about, that brings so much anxiety to them, is their health care. So I urge you, please, with everything you have in your capacity, tell us what you need to help you move away just from processing $800 a month. If it's a budgetary issue, we will be more than happy to advocate on your behalf. We want to partner with FSSA. We want to support your work. Our goal is shared. So this is not us versus you. We want to be sure that these constituents are being served. So I appreciate you for listening to my concerns on behalf of all those who reached out to me.
Thank you. And I will just add, we'd be happy to look into those individual constituent issues. And we can also follow up with Senator Becker as well.
I appreciate it.
Happy to do that.
Thank you.
Okay, I think Representative Campbell, Representative Shackelford, Representative Clear, and Senator Yoder, I will say it is 12 o'clock. And so I just want to be cognizant of our guest from the Division of Mental Health and Addiction, who's here to present on CCBHC as well.
Okay, I'm just trying to get some clarity on this. So the 9,000 people, are these new waiver transitioning to pathways, or are these our prior waiver transitioning to pathways?
They are new. They have not been on the waiver. So individuals that
Okay.
were previously on the waiver are on the A&D waiver and are over 60 are on the pathways. waiver.
Okay. Just kind of going similar issue. I had also a constituent who had her supplies for incontinence covered in full. She's on disability, very limited, just on disability funding, and can't afford extra to get supplies. So she's now not able to get the supplies that she needs monthly and has had a disruption in getting her supplies. How can we best help our constituents address this issue, make sure that, why are we losing coverage that they had going from the waiver to the pathways?
So they shouldn't have lost any coverage. I want to make that clear. I think there's some confusion too with some of the providers have confusion, thinking that they're not participating in the Pathways program, even though it's an open network. And if you are a Medicaid attested provider and you were doing it under the A&D waiver, you are doing it under Pathways. So there was some confusion around that as well. If you have constituents that are reaching out to you saying that their service is stopped or they're no longer getting this,
Covering 3/4 of what she needs to make it through a month, and that's not enough.
yeah, so then please refer them to us. I mean, we create those.
What is the best
Yeah.
direct contact to get, is it one of these?
Yeah,
I'm sorry.
There.
If you would please, if it's a constituent concern that's coming to you as a legislator, if you would please work through us, that will just help us make sure we're tracking it in the correct way and responding to you and or the medical member appropriately. So feel free to reach out to the table.
Thank you.
Package these and.
Thank you.
Yes.
Thank you so much.
No, thank you for your question.
Okay, thank you. And I apologize for the time that I'm going to take. Because I work in this industry, I do have about 7 questions. So I don't know if we may want to have the next presentation moved to our next meeting, but I feel that this program and our seniors is too important that we don't take time to flesh out these questions. One, I just want to make sure the understanding between the information that we're getting for our staff on this wait list is that Indiana was supposed to fill our slots before we actually formed the wait list. So if our slots are still open, then why do we have a wait list?
And I want to make sure I understand your question. Sorry. I want to make sure I'm understanding your question. You're saying that is the interpretation from CMS or?
Yes, do we have open slots?
I don't want to misspeak on that particular question. Let me try to get that exact information. We have we have projected the number of slots that will be used and are onboarding people from there, but let me get specific information for you on that so I don't misquote any of the stats.
Okay, and then I'm looking at your dashboard. I would love for the open slots, the slots available actually to put on there, because I do see that you're taking people off the wait list, but I don't see what our capacity is, where those slots are.
Okay, thank you for that feedback. I'll take that back to the team working on that and see what feasibility we have there.
Okay, the next thing is on reimbursements. So I was just at one of my assisted living facilities last week and got an earful, not only from the residents, but from the owners. Now, I know state is usually behind on reimbursements, especially when it comes to Medicaid. But what we're seeing as we go into pathway with aging is claims and reimbursements are running behind about a year, about 12 months. And some seniors are at the eviction point because these facilities have not been paid. Basically, reimbursements have stopped or they've been very convoluted. And not only did we hear from the owners, but we also heard from the seniors that are facing some evictions. So I want to make sure that we look into processing reimbursement and claims because what we're hearing from providers is that there's been a true delay in getting these claims processed.
Sorry. Thank you for that. So the Pathways program has only been live for about 45 days. So if there are year-long outstanding claims issues, that's really not due to the Pathways launch. I'm not aware of that being the case, but again, we're happy to look into specific provider matters. And if it is a Pathways matter, if it's a fee for service or pre-Pathways launch issue, we'll dive into that. And if it's related to a managed care entity, we're also happy to quickly get with the MCE that's impacted and see what the holdup is for that particular provider.
Okay, and one more issue with the providers is normally this assistant living, they process about 5 to 6 admittance a month, but with the new pathway process in place, they're only getting 0 to 1 a month. They said there's some type of assessment requirement from the MCE that's now required. So that's taking time as the senior is trying to transition into the assistant living. So can you also take a look into that?
Yeah, we're happy to. And just a broad comment that I will make is it's very helpful. It's challenging when it's sort of anecdotal information. So we really encourage providers to contact us through you all if we have the specific provider information that really helps us, the state and the MCE, pinpoint the root cause issue and make sure that we're solving for the whatever the problem or the holdup is. So if we can have specific provider information, that's extremely helpful and we'll commit to quickly resolving this. Holly's team is sort of I would say, in the implementation phase. They are doing daily, like she said, daily calls with the MCEs. We have a platform to talk with them every 24 hours during the business week about what these issues are. So if we know about them, we are addressing them in what I would say is rapid fashion. It's just challenging when we don't have the specifics to really pinpoint what the underlying issue is. So,
Okay, I'll make sure that you get that information.
Great.
My next question is on slide 27. I've heard from numerous seniors that when they call into the enrollment broker or when they call into customer service, the customer service reps aren't knowledgeable on the Medicaid program. They don't understand the differences between the plans. So it's hard for them to make a choice and say which plan they want to be on. When we go to your website, mostly everything that's listed kind of in that grid format, all the MCE's information look the same. You have to click on their website and actually go to each MCE's website to start seeing like detailed information as far as how many dental visits are covered or vision. Is there any way that we can get some type of side-by-side grid or some grid that's put together that's similar to Medicare Advantage plans? Because they're used to having a booklet and seeing those grids and actually going down and see what the service is and how much is provided, versus they're not able to go on a website and click through all these clicks to finally get to something.
Can take that back for sure and see what we can put together.
Okay, great. The other issue I wanted to bring up is case management. There's a number of companies, as we know, that did not accept the reimbursement for care management and coordination. Large companies, including Socoa. So what has happened is the seniors now are caught in the middle. They don't have a care manager. There is a backlog, there is a delay. If they don't have someone to coordinate their care, which is why you're seeing a lot of calls from the members and from providers, the first thing on here is care and service coordination, because there's a backlog of them actually getting another case manager. What does that look like? Have you guys heard anything about this backlog?
So just a clarification that I want to provide is that everyone in the Pathways program has a care coordinator. Waiver members, those that are on the Pathways waiver, have a care coordinator as well as a service coordinator. So the work that the AAAs, including Socoa, had previously been doing, and Holly has some information about those that are still participating, that's on the service coordination side. The care coordination side is entirely on the MCE side. So just wanted to provide that. Every Pathways member has been assigned their care and or service coordinator and has that. As you can see from our member support services slide, that's a common question we're getting is, I want to know who my care coordinator is. And so we've been working with the plans. They're continuing to do outreach, but also we've instructed each of the 3 MCEs that they have to have processes within their phone trees to be able to quickly route the Medicaid member or their authorized representative to the care service coordinator or, you know, the appropriate representative for that issue. What would you like to add?
Yeah, and I'll just add that that was one of our on the spot audits that we did. We sat with customer service and then we heard a lot of calls of who's my service coordinator. And then we watched the process of those member service reps for each MCE be able to pull up that information or they couldn't pull up the information. And so that then prompted us to put in place, you need to have these things, you know, you need to make the whatever configuration changes you need to make, but your member services reps have to have access to this information. And so we have seen, and now we're going back, we did the first calls about 3 weeks ago. We're going back in the next couple of weeks to then re-listen to calls again. And so we are learning things by doing this as well, where, you know, if it's confusing to us, it's going to be very confusing to people calling in. And so we're trying to make those tweaks and make sure that everybody's doing the same thing and they're all getting the same information that they need to get when they call in. So we've got some things in place to stay on top of that and track that they're doing what needs to be done to serve the person.
Now, can you tell me what is the process of how will a member know who their care service coordinator is? Are they receiving a letter, an email? What are they getting from their
They should be getting calls and they should be getting letters as well saying, here's your service coordinator. And so they should have both of those things. And they should have made I mean, the MCEs have assured us, I don't have anything that tells me this though 100%, but they assured us that they have made contact or calls out to every single person that is on the waiver. So if they haven't made contact, sometimes it's because of our lack of contact information, correct contact information. So they're circling around and trying to figure those things out. But they or to have a face-to-face with everyone within this first 90 days that is on a waiver. So that should hopefully close some of those loops of people not knowing who they should be talking to.
Okay, is there any way we can get a copy of those letters? The communication has gone out to
Yeah, we
members.
can.
Okay, that'll be great. And then just a couple more items, ID cards. People are confused. They have their Hoosier HealthWise card. They haven't gotten new member ID cards from the MCEs. Some have, some haven't. How is that process actually supposed to work? Should they all have new ID
They
cards
should all
from the
have new
MCEs?
IDs, cards from the MCEs.
Okay.
If they don't have, if they did not receive it, they can call the MCE and have them send them those. If they don't know their MCE, they can call our members support services line, or they can call Maximus, which is the enrollment broker.
Okay, I will give them that information because I think there's still confusion when they try to call that line. And then this is just my last suggestion. I'm not going to dive deep into the claims, but I sit on the All Payers Claim Task Force, and we just launched the Indiana Claims Database. Medicaid information is not in there, neither is Pathway. So I was wondering, is Medicaid claims going to ever be in there, or Pathway claims?
I'm gonna.
I'm sorry, just letting people know that we won't be able to get to the CCDHC presentation. So
Okay.
the question was about the all payer, I'm sorry, Representative Shackelford, the all payer claims database.
Yeah.
Are-
Will Medicaid claims ever be in there, especially the Pathway claims?
Yes, I believe Medicaid claims are in that database, or if they're not, they're being added to that database, which will include Pathways claims.
I think one of your team members is trying to say something.
Oh.
Yeah, they're not
actually?
currently.
Excuse me, could you ask him to speak into a microphone so that
Yes.
folks online can hear, please?
Brian Airwood, FSA Chief Information Officer. I'm on the All Payer Claims Database Board as well, the advisory board. Medicaid claims are absolutely in there. I think one of the things that they were presenting last week, if you're talking about the presentation from last week, is that for pricing purposes for the transparency portal, because Medicaid members don't have sort of a price on their side, that's all commercial based claims,
Mhm.
if that makes sense. So data is in there and they use it for other purposes, but not the transparency portal for the pricing.
And then when will the pricing information be in there?
There's not really pricing for Medicaid constituents, if that makes sense.
Since it's mainly government
So if I'm going to
funded.
get something done to my knee, the price is zero. Does that make sense?
Yeah,
For a
that makes
Medicaid member.
sense.
So it doesn't make sense to have it on the pricing portal.
Okay, that makes sense. Thank you.
Sure.
Thank you, Brian. Okay,
Those are all my questions.
thank you, Representative Shackelford, Representative Clear, and then Senator Yoder. Oh, I'm sorry, and Representative Garcia Wilson.
For me.
No,
Oh.
I think 1, 2, 3.
Thank you. So let me preface my questions and comments by thanking you and your team for everything that you have done and are doing. I appreciate all of the information, and I know you all are working hard to make this work. I just think well, I know that the experience I'm hearing about is in the field is very different than what we're hearing when we look at call abandonment rates of less than 1%. And I'm not talking specifically about the abandonment rates. I'm just using that as an example. But knowing that we're short on time and there are others who want to ask questions, I'm going to try to do this in lightning mode. Easy question. Changing MCEs, they can change in the first 90 days, and they can change once per calendar year. So can they do both? Because that question has come up at home. So
Yes.
So they could someone enrolling in the Pathways Waiver Program who is assigned to or selects a particular MCE could change MCEs, could change to another MCE within the first 90 days of their enrollment.
Correct.
And then in the remaining what, 275 days
Right.
could change again.
Right. They can-
So effectively, they can change twice per year. One of those changes would have to occur in the first 90 days.
Correct.
Here, that 90 days of certain coverage is really an implementation.
Yeah, so from their,
For the
yeah,
first
for
year of the
their-
program,
yeah,
so July
for their
1.
enrollment date. And that would be for anyone. So even after the first year, if they come into Pathways, it's always 90 days from their initial enrollment date. Yes.
But then once Pathways is 1 year old, they wouldn't be able to change. Is anybody entering the program at that point would only have the 90 days. They wouldn't have the 1 year option as
They
well.
would have the 1 year option. So the 1 year option is their Medicaid redetermination date. So on their annual Medicaid redetermination date, they can change their MCE. Within the first 90 days of them enrolling in Pathways for the first time, they can change their MCE. And then if they are a dual, they can also change during the Medicare enrollment period, or make the request to change like January 1 with during the Medicare enrollment period.
So the once per calendar year, you're saying relates to their Medicaid recertification date.
Correct.
So it's not discretionary at any time after the 90 days and prior to the redetermination date.
Right. It would be it's within 90 days of their redetermination date that they can change. So that's a constant. So annually redetermination date, they can change their MCE. They can change for just cause as well. So if the provider's no longer in network, or they have other concerns with their provider, they can also change during that time.
So basically right now everybody can change because we're still within the first 90 days. And then after the end of that 90 days, so July, August, September. So after September 30th, essentially, or 29th or something, then they won't be able to change again until one of those other conditions is reached, including their Medicaid their annual Medicaid recertification date. And then the other reasons you listed. So, okay, sorry. I thought that was an easy question and then I confused
It's
myself.
clear that actually makes me think it is so complicated. Perhaps in our FAQs on our website, we could build some example, like person A comes on this date. And I think that might help because your questions are very valid and it is confused. And in an effort to give lots of opportunities for plan change, we've made it a little more complicated.
Yeah, I think that's a great idea. I would appreciate that because this question is coming from constituents who have asked me about it here in the last few weeks. So you coined a new term. I, until today, had never heard the term post-live readiness, which I find terrifying, by the way.
Just so you know.
Secret shopper results and data. How can we get that? So it's less secret.
Yeah, we can provide that. Absolutely. We can, in fact, we can provide any of our on the spot audit data that we put together. We actually do website checks and so we've been trying to do all of those things to make sure that everybody's aligned. So I can, we put this into a grid. I can share that. We can make that available.
Well, I would love to have access to it, and I think other members of the MAC would probably appreciate it as well. But I know there are folks in the public who would like to review that.
We can take that back. And
Yeah, and I would say also, I fully anticipate we will do another Pathways update at our November meeting. And so we could weave that in those results, update the data we have in here and weave those results in as well.
So let's talk about the dashboard for a second. Several comments have been made about the dashboard. And you've already talked about some updates or some changes that you might make to the dashboard. I would like to see on the dashboard how many people who were on the waiting list not only end up with a Pathways waiver, but how many had some other change of status while they were on the wait list that ultimately kept them from qualifying for a waiver. So in some few cases, it would be that they're no longer eligible. But unfortunately, in many cases, it's going to be because they entered long-term care, or they died. So what do you think about breaking out different categories on the dashboard so that there's accountability around that going forward?
Yeah, I think we could, similarly to the open slots question, I think we can
Yep.
definitely take that back to the team that's kind of reviewing that.
Thank you. The link for the dashboard, would you ask Ms. Slade to email that out to the MAC, please? So the wait list, is it 125 a month for the health and wellness? Okay. So I ran the numbers real quick and somebody can check my math, but based on the numbers you provided, the pathways waiver wait list rounded, I got 11.56 months. So rounded, it's 12 months at this point, which means it has grown by about a month since the data that I received in July. The really scary one is the health and wellness wait list, which, if my memory is correct, I don't remember. I want to say 25. No, it was 2.5 years. It was 30 months in July when I ran the numbers. But again, if my math is correct, it's increased by more than 5 months. I've got 35.45. So we'll call it basically a 3-year wait list for health and wellness. So we have a 1-year wait list for pathways at this point and a 3-year wait list for health and wellness. Does that sound correct?
I haven't run the math exactly like that, but that sounds in the ballpark. Well, I'll let you finish your question.
That is the question. I mean,
Oh,
I have follow-up
okay,
questions,
making sure.
but making sure that, I mean, again, we have lots of smart people in the room, so somebody check my numbers, but all I did was I took the 9247 on the pathways waiver wait list and divided it by 800. And that's how I got 11.56 months. And then I took 4431 on the health and wellness wait list and divided that by 125. And that's how I got 35.45.
Yeah, I have the same math, Rep. Claire.
Thank you.
So thank you for that. I think one thing that we are doing, we're convening a work, because of the success of the claims advisory work group, we're convening a work group to start thinking through what are the processing pieces of the waitlist invitation to see what efficiencies might be there as far as the numbers that we're inviting each month. And then also we are trying to make sure that we're finding ways to work through that more quickly. For example, for the individuals who don't accept the waiver or have moved out of state, we're adding those right into the next month's invitation so that we are trying to get as close to those numbers of actual waiver enrollment and working through the process more quickly. So we hope to have more updates to share again at the November MAC meeting as we talk about some of these things and pulling in providers and the AAAs and everyone and the MCEs, if it's a pathways waiver, trying to make sure we have strong understanding of all the different operational inputs and where there might be places we could speed that up.
So the consequence of the wait lists is that we have individuals who are not receiving services they need and services for which they qualify. So I have a growing list of such cases. I have in my hand a note card from a coffee and conversation session that I held several days ago in New Albany. And this gentleman came to me with his father's case. And I think it's a great example because I've seen a number of cases like this, and it's very concerning. His father went through the Medicaid application process back in the late winter, early spring, and the family has done everything that they should do. They have sold his house. He has apparently early stage dementia, and he's now in assisted living. But they sold his house, and they've dealt with all of his assets and worked with Medicaid to talk about spend down and at what point he would qualify for Medicaid to start paying for his assisted living. So whenever the notices went out, I forget, was it the wait list, April, yeah. So in April, this family that thought they did everything right, and in fact did do everything right, and now dad's in assisted living and quickly depleting his modest resources, receives a notice that he's on the wait list, which now the wait list is a year long. So the family is understandably terrified that dad's money is going to run out before he receives a quote unquote invitation. And they don't know what will happen to him at that point. The assisted living facility is not likely to say, hey, just hang around for up to 12 months until FSSA sends you an invitation. And I don't mean to be flip about it, but I mean, he was very emotional about this. And I've worked with a number of other constituents who or a number is understating it. I've worked with a bunch of constituents at this point who are experiencing similar circumstances. And I suspect my colleagues, I see Senator Cadora nodding. In fact, I see all of my colleagues nodding. So I think we're all hearing similar things from our constituents. And, I know the party line is the General Assembly has to appropriate more money in order to open up slots. But my gosh, first of all, shouldn't this have been anticipated? When we were barreling forward with Go Live, this was, Pathways was being advertised on television and radio, and we were just, building the wait list before the program ever started. So I've got some more questions, but I'll stop there because, again, I appreciate everything you all are doing, but, having reports of where things stand does nothing for the families, the individuals and the families that are being impacted, including the constituent I just talked about. So what do we do to fix this so that dad does not end up without the ability to stay where he is in the assisted living center, assisted living facility, and this family doesn't have to worry month after month as they are now?
Thank you for that, Representative Blair. We have had productive conversations. Obviously, the assisted living facilities have raised this particular issue with us is for individuals who were in sort of this resident spin down space and at the time of the announcement of the wait list. And we are actively exploring some short-term solutions for them from a financial standpoint through perhaps HCBS spend plan dollars that are available that we've received through enhanced FMAP. It's ARPA money that has to be used coming up here shortly. So we are having conversations with them about a narrow path for these individuals who are kind of caught in this in-between space because of sort of the challenges around assisted living specifically and the wait list situation.
Well, and I appreciate that. So it sounds like a very appropriate use of any remaining ARPA funds. Would that apply only to individuals who went through the application process prior to the announcement of the wait list, or would that pick up families, who end up experiencing the same sort of thing going forward?
We're still designing a little bit and having conversations with the association and most importantly, trying to size up the population of who may be then eligible under the various criteria. So we'll definitely be sharing more details quickly in the coming weeks.
Well, let's design it in a way so we don't leave anyone out. How about that?
Noted.
And I appreciate the attention to assisted living. But there are also individuals and families who need home services, waiver services at home. So would this potentially help them as well? Because there's tremendous pressure on those caregivers. And what happens is if the family caregiver can't handle it and there aren't services available to help the family caregiver, then the person may end up in long-term care.
Understood. I would say we're exploring options to try to help in as many individuals as we can within sort of the limits of what is available, and see where we can end up. But definitely from the waitlist standpoint, we hear and recognize the concerns.
Would you keep all of us, legislators and MAC members, more broadly updated as those discussions continue?
Happy to do that.
Certainly you can communicate with the legislators through Captain Smith, Gus, Mr. Hapig. Sorry. But I think it's important. I don't want to wait until the November meeting
Understood.
to know what's going on. And I think we all need to have the same information going forward. I've experienced the same issue with incontinence supplies that Representative Campbell mentioned. It's hard to understand. I'll put it that way. Let's see. I'm crossing things off. I'm trying to be quick. We talked about the secret shopper data, so I really want to see that. Circling back to a concern that I raised at the last MAC, which would have been May, yeah. I brought up the Anthem NDA issue. What was the resolution on that?
So we confirmed that is part of their business associate. Oh, I'm sorry, not their BAA.
Yeah, so anytime that, what we confirmed was that anytime they go into contract negotiations, the NDA is specific just to the contract negotiations. It's not, it doesn't go beyond that. So once the contract negotiations are complete, then the NDA really goes away because they end up signing the BAA, which then outlines the parameters of the relationship.
Right. My understanding, though, the way it was explained to me, the BAA then includes its own NDA.
Yeah, but the NDA does not keep the AAA or any vendor for that matter to raise concerns with the state regarding the MCE or the relationship with the MCE. It really keeps the proprietary. It's there to keep the proprietary information within that relationship.
Well, it doesn't necessarily keep them from raising issues with the state, although I think there could still be a chilling effect. But it would keep them from sharing their experiences with other AAAs. For example, they couldn't have conversations within the I4A community without violating the NDA and the BAA, could they?
I believe that that's not. I'm not an attorney, so I hate to comment on that, but that was what the information was. It was shared back that it shouldn't have prevented them from talking about normal day-to-day activities. It was just to protect the proprietary.
Will you please continue to follow up on that in the interest of time? Just follow up on it and provide more clarification as to what the NDA that is part of the BAA would preclude.
We have to approve the BAA, we have to approve any of the documents that they use in the contract, so we would have that information.
Specific question on slide 32, the MCE member helpline call data, July 1 through August 17. Why is Humana such an outlier?
It's because they don't right now, they're working on it, have a mechanism.
You might want to pull the mic a little closer.
Sorry, thanks. They don't have a mechanism in place right now to distinguish someone calling in regarding their DSNP benefit or their DSNP questions versus someone who's calling in regarding pathways. And so they're working on configuring something that will allow them to pull pathway specific data and not include folks that are also calling in regarding their DSNP, their aligned DSNP companion Medicare program.
So, bless you, you think that the roughly 9 or 10,000 variation would be attributable to the DSNP calls?
Yes, it is. That's what when we've gone back to Humana, that is what the difference is.
Okay. What about caseloads relative to the RFP and the contracts that were executed?
So the The service coordinators have caseloads that are similar to the A&D. So they aren't to exceed more than 65, 66 individuals that are in a home and community-based setting. And we've been monitoring that. They've had to provide us ratios every couple of weeks. We ask for it. And that they are all maintaining about that ratio right now. I would say probably the first 3 weeks or 4 weeks or so, there it was more around 70-ish, but they were onboarding more people, getting their service coordinators trained and in place. So that has come down, and it is more within that realm of 65 to 70. And then for care coordination, those numbers are a little bit different, because if you're in complex case management, then that's a lot more labor intensive for a care coordinator. And so those caseloads should be lower. A typical care coordinator, though, would have anywhere, if they're not doing complex case management as well, should have anywhere between 300 to 600 people that they have on a caseload.
A care coordinator.
A care coordinator, just doing regular care coordination, not complex case management.
So differentiate, please, among case management, care coordination, and service coordination. Service
Yep.
coordination is
It's tied to the waiver.
well, yes, and service coordination is what some of the AAAs are subcontracting to provide.
Correct. Yes, correct. And then the care coordination is generally the more lighter touch of a licensed individual helping a member with appointments, or helping someone understand what the doctor's needing from them, or their medications. Complex case management involves a individual care plan that's a patient-centered care plan, and is different than like the waiver service plan. I mean, they go and can together, but it would be more focused on those very high need diagnosed individuals that have those high needs diagnoses.
So are all caseloads at this point at or below the contract requirements?
I would have to pull that information. I have not looked at that in the last week or two, so I need to double check that for you.
Okay. I've only got one or two more. Let's see here. Oh, on the temporary emergency financial assistance, you said we have 165 providers who have applied for that program. 165 applications. Okay. But if everything is working so well, then why?
I will say that at the outset, we could have probably communicated with more clarity about what that was. And there were quite a few providers who believed this was a grant rather than a reconciliation against future claims payment. And so they applied thinking this was a grant opportunity where they would receive funds, which is not what that particular program was.
Oh, they thought it was free money.
Yes.
Okay, well, no.
And I would say probably 25% of all of the applicants are they're ineligible for the temporary emergency financial assistance because they did not participate in the claims testing period.
Okay. Skipped over a question on the case managers, care coordinators, service coordinators. Has everyone received training at this point? I mean, are they all trained? Everybody who is in these roles?
Yeah, unless they're in the pipeline.
I
Yeah.
mean, they're going to be new employees, right?
And then they all have to be person-centered, trained on the person-centered thinking process as well.
And back to the helpline, the member helpline slide again, slide 32. Not right now, but could you send out to the MAC, including all of the legislators, the breakdown of the call reasons? You have top call reasons, but it doesn't say like 20% are care
Correct.
Coordination and clinical support needs,
Yeah,
et
these
cetera.
were the top call reasons that were pretty consistent week over week. Because that's how we receive it, is week by week right now. So I wanted to try to just give you but yes, I can give you all of the call reasons.
And that should suss out the DSNP issue as well, right?
It doesn't, because they could still be calling, they still have care coordination and on the DSNP that could still be a benefit. Yeah.
Yeah, makes sense. Okay, I think that's all I have for the moment.
Okay, thank you, Representative Garcia.
Yes. Unfortunately, my question wasn't among the list of the questions Rep. Claire had. So I was hoping, but it wasn't. I just want to frame it really quick, right? So aging in place is not only encouraged by CMS, but it's a return back to patient-centered care that is so desperately needed among older adults. And it also overwhelmingly saves us money, whether we're in this state or any other state. So just a question regarding what is exactly being reimbursed, because there was an article that came out just today, actually. And on the FSSA website, it states you will continue to receive the same Medicaid benefits in the Pathways program. So regarding Medicaid approved transportation, is this currently an issue? Where are we with that? Because there is apparently some ambiguity in services not being reimbursed. Can you elaborate?
Right, so all all waiver services as they were provided under the A&D are covered under the Pathways waiver. When it was brought to my attention that there was some MCEs not paying the waiver transportation, we quickly circled back with the MCEs, had them research, are you denying that, and it was procedure code T2003. Are you denying this code? What came back to us was we had one MCE that said, yes, our system was not configured correctly. We have corrected this and we will be reprocessing claims. The other two said, we're getting lots of claims submitted with the T2003, but no modifier. And for the claim to pay, they have to include the modifiers. So I would say that when we were looking at that slide of the claims payment, a lot of there's 50% are the MCEs making sure that their systems are configured correctly, but the other 50% are really educating providers that they've for some reason, one reason or another, Gainwell has paid their claims in the past with this partial information and not the full information. And it is us trying to make sure that these providers understand, no, you have to include the modifiers. You have to include the right procedure codes. You have to provide the right Medicaid ID or provider ID when you submit the claim.
So now we're going to educate everybody appropriately.
Yes,
So that's going to be rolled out.
And actually, just so we have a bulletin coming out, I think it's tomorrow, that clarifies the difference between non-emergent medical transportation and then non-medical, which is the waiver transportation. So there's a bulletin that's coming out on that. I've asked also the MCEs to put something up or put a bulletin together on their end too, to explain how to bill the T2003. So they're working on that too.
Yes, as you know, transportation is so vital for aging in place. So thank you for correcting that expeditiously.
Yeah, and I've been working with the chair of the Adult Day Association. President, so on this as well. So she's been able to provide me with some feedback and some examples, and that's how we were able to isolate the issue.
Thank you for that update.
Thank you for the question. Senator Fedora.
One question
Sure.
or data request, if you don't mind, since this is the end of an administration and we don't know what will happen in January. We have a budget session, and I know that each agency has to submit their budget requests to the governor. And I know we come up with our own budget in the General Assembly. Is it possible that you can share with us some estimates or projection or details if we desire as a General Assembly to completely eliminate the wait list for both the Pathways waiver and for the health and wellness waiver? What would the cost be? I understand it's two components, the projections of the aging population plus the actual the number of people plus the cost between the state. So I just want to know hypothetically, if money was not the issue and the state can come up with the dollars and we would go back to CMS and increase the number of open slots, what would that cost be? Is that something that you can provide us with?
Yes, I believe that we can. I'd like to go back and talk with our finance team and our chief financial officer. I would say with the improvements that we're making to the forecasting process as well, we anticipate receiving requests like that for information about how much would a given Medicaid policy change cost. And so we're building in enhanced processes to ensure we can deliver that type of information for policymaking discussions.
Excellent. We appreciate you for that. And if you can include if there's any staffing need, meaning that if the logistics within the agency, whether it's IT or human resources are needed, please let us know what that cost is, because the two most important functions of state government is education and healthcare. and they consume more than half of the budget. So we just spent close to $2 billion on capital projects, one jail on the north side of Indiana, and $250 million on rest stops. So it's not a matter for us as legislators that there's no money in the budget. We tend to find money for all kinds of issues. So we want to be sure that we truly can help those who are in desperate need to get that resource. I appreciate it. The sooner you get us that information, the better.
Thank you.
Thank you.
Representative Shackelford.
And I just got a couple more requests for our next meeting. I'm assuming we're going to get a pathway update in November, seeing we'll be in the midst of AEP for Medicare. Can we make sure the MCEs are here in case we have questions directly for them? And then, great. And then two, I'm hearing a lot of challenges with home health care. I know Pathway was created to let our seniors stay at home, but that home healthcare system is still not built out the way it needs to be built out. I'm hearing those challenges as far as they can't find providers. The providers are not doing background checks. The providers are sending family members over at the last minute. The providers don't know the health of the member. So say they don't know if someone's is diabetic before they start making them food. There is complications between, say, if there is a husband and wife there, them just working on the Medicaid patient, having a line between exactly what they can clean, what they can't clean, what they can cook, what they can't cook. But I'm looking into submitting some legislation just to crack down on home health care and what that looks like for next session. And I wonder that you all have any concerns, or are you working on anything for home health care?
Thanks for that. I think we'd be happy to share some information, either in the November as part of November Pathways update, or additionally about some of the pieces of that. I think we've heard questions about, it's a confusing regulatory structure, to be quite honest, between the Medicare and the Medicaid regulations. So we're happy to help provide information if that's what we're looking for.
That'd be great. Thank you.
Okay. Great. Okay. Well, I think with that, I don't see any other questions, no comments online. So with that, we will, Representative Claire.
Sorry. Given how much time this took and that all of these issues are still going to be with us in November, would it make sense to schedule more time for the meeting? I would suggest at least 3, if not 4 hours, depending on how many presentations you have scheduled.
We will definitely take that back and talk with, the team on how to do that. I would like to do the Certified Community Behavioral Health Clinic update first next time, because it is really timely and something.
Absolutely. I hate it
yeah.
that we didn't have time to get to it today. And I'm just saying I think it's easier for everyone if we block out more time, and if we finish early, then great, but it's much harder to schedule 2 hours and then do what we just did, which is go almost an hour over. So I'm suggesting we schedule 3 or 4 hours, and if we end early, then great. For him, absolutely.
Thank you. Okay, with that, do we need a motion to adjourn? Entertain a motion. Thank you, Senator Kadora. Second. All those in favor? Aye. Thank you. We're adjourned.